so much for coming. Let's give a big shout out to Brent and Lauren, wherever other Lauren is, part of Hillsdale. So maybe about 20%, 30-40% of you guys came last year. So thank you all so much for coming again this year. I am Sarah, and I'm part of the Parkinson's Activity and Resource Center, a nonprofit here in Charlottesville. We have Naomi in the back. She is through APDA. Then we have Renzo Fagari from UVA, and Dana.
That's still okay for you?
She's back there. They all helped put this together. So let's get started. Maybe. Lauren, it's not working. It's not working.
Apparently, I have to have the
Make sure everyone's muted.
Zoom app, and I don't have that on my iPhone, on my iPad.
All right, we're gonna get the Zoom people muted. All right, so all of you will have the schedule on your table. We do have some breaks here scheduled. Feel free to leave as you need to. And then at the very end, we have a social hour, so we'll have some food.
What's going on right now? Welcome to my world.
All right. All right. All right, so some guidelines for the day. So after each presentation, we're going to have about 10 minutes of question and answer. So please keep all your questions till the end of the presentation. Please respect all questions that are asked and how they are answered. Some people may have opinions about something. Just try to keep that to yourself. We have 2 15-minute breaks scheduled through the afternoon, but please take breaks as you need to. And again, we're going to have a social hour at the end of the event with food and drinks. So, like I said, what's on your table? We have the schedule for you. Please feel free to take notes on that as you want to. Also, on your table is a survey. Please use it throughout the day to fill out your feelings on each topic and how it relates to you. On the very top, it asks you, do you have Parkinson's? Are you a care partner or a family member? Do you work with people with Parkinson's or other? All right, to get started, we're going to hand it off to Dr. Fagari. Oh, not yet.
Hello?
Hi, thank you, everybody. I don't like standing on the podium. I'm more like a person that walks around the stage and try to connect with everybody. I copy that from those tech videos that you see the fancy CEOs walking around. So I'm gonna pretend I'm a fancy CEO. Well, I'll talk to you about a little bit about exercise and why is this important and why I always, if you've see me in the clinic, I always tell you that the number one prescription, as important as any medication I could give you, is exercise. And you should put that on your schedule in the same way you think I need to take my pill in the next hour. You need to think I need to take my exercise today, and that should be part of your routine. So just gonna brief overview. We're gonna do some review of what our current practice and what are the options that we have, and then how my final thoughts on how we should approach exercise. First of all, what are the benefits of doing exercise, or why do we tell patients to do exercise? Of course, the number one is because we want to improve your level of function. We want you to be able to do your daily activities at home and overall improve your quality of life. And as you can see with that graph, in the last 10 years or so, 15 years, has been an explosion of research done in regards of exercise and the benefits of exercise, with very little published in the 90s, and now hundreds of patients being published every year. So before we talk more about exercise, let's try to define a little bit what we mean with exercise, so you understand also what are the things you need to do. So when we say exercise, is any type of activity when you're contracting your muscles that is making you expend more energy than your baseline, okay? So if you're washing the dishes, doing the laundry, that's not exercise. That's so that's life. So we need to spend more energy than usual, okay? And you're gonna hear me talk about moderate exercise, or moderate intensity, and high intensity. How do we define that? And that's based on what is your maximal heart rate, which is gonna be something you're gonna calculate based on your age. So anything that will raise your heart rate to about 50 to 70% of your maximal heart rate, that's gonna be a moderate intensity exercise. If we're gonna raise to 70 to 85%, that's gonna be your high intensity exercise. Okay, so just to review, this is the formula that you have to use. The simplest one is just doing 220 minus your age, but a more precise way to do it is 208 minus 0.7 your age. Okay, so 70% of your age, and you subtract that to 2008, and that will give you what is your maximal heart rate. And then from there, you can calculate what is that. So let's, as an example, somebody who is 70 years old, we have using our formula, 0.7 times 70 is 49, minus 208 is going to give us 159 beats per minute. With the other formula, it will be 150. So you see, it's a little bit of a difference, but not too much. So once you know, okay, this is my maximal heart rate, then you can calculate for a moderate intensity exercise, I need to raise my heart rate from baseline to at least 80 to 111. And that will be your moderate intensity exercise. Your high intensity exercise is when you go from that 111 to 135. So that puts you kind of your limit of where you want to get when you're doing a high intensity exercise. Okay. Now, before you start doing all of these exercises, one thing that we always recommend is doing therapy. Okay, I'm not just gonna put here what is that kind of our standard of therapy, the LSBT big. Who is familiar with LSBT? Who has done that before? All right, so I see a few hands there. So LSBT, or Lee Silver voice training big, which is the physical part of this exercise, is focused on the amplitude of the movement, big movements that will help you with your mobility. But it's a very standardized treatment plan. You have 16 sessions over 4 weeks, 1 hour each session. So it's very intensive, very involved, and you need a therapist to guide you through that. Okay. And we know that with this type of exercise, we are going to improve patients. There's data that show us that if we look at the motor symptoms, we measure that with this scale that is called the UPDRS. Their UPDRS stage, the 3, is what is telling us about the motor symptoms. We can improve those motor symptoms in patients after doing this type of therapy. But a lot of times, patients will do the therapy, and then after that, they go back home, and they may not know exactly what to do, or they just don't have the motivation to keep doing it. And they go back to what things were before doing the therapy, and they come to the clinic and say, well, therapy didn't do anything for me. Okay, but I tell them, what happened is that you didn't do anything for therapy. Now, what is happening around the States is that when we look at how many patients are actually referred for therapy, we are only on average 15% of our patients are being referred for therapy. So that's not too much. And if we compare that to what Europe is doing, in the UK and Netherlands, almost 60% of those patients are going to physical therapy. This is a little bit of a graph of where the amount of patients that are going to therapy. So you see there are some states that are really way below in the amount of referrals for physical therapy. So this is what I was talking. What happens after that? What happens after therapy? And here's where we're going to try to get more into this lecture and try to look at the things that you guys can do at home for yourself, for your Parkinson's disease. And we're going to see some of that. So there's plenty of exercise. I'm going to go over a few of them. This was a very interesting study that has a nice story of how it was started. This was a physician. I think it was somewhere in Europe. He decided to do an event for awareness of Parkinson's disease. So he grabbed a tandem bike, and he will be riding on the front, and he had a patient with Parkinson's disease riding behind him. And he will go stopping at different places and talking about Parkinson's disease. But then he noticed that whenever they finished riding and they stopped, his patient was doing better. Even if he had missed his medication, he was able to move, he was able to walk better. So we started thinking maybe that what we call forced exercise, because I'm forcing him to go at my pace, was thinking the physician, is going to be helpful for this patient. So they look at that, and there was a few studies of this. We're going to put patients on a bike, and we're going to force them to go at a rate. And then another group, we're going to just give them a bike and just tell them ride at your own pace. And you can see that there was a significant improvement on their motor symptoms. Again, from this we call forced exercise. Okay, and from that, I don't know if you ever heard of this, the TerraBike. Has anybody heard of that before? Yeah, so a few people has seen this. So these are bicycles that actually force you to go at a specific pace. So it's not just your regular bike. And they're a little bit expensive. I think that they have come down quite a lot from the first time I did this lecture. The first time I have to pull these images from, they look like a monstrous. It was a huge bike that now they're still they made it look a little bit better, and the prices have come down. But this is one option. I'm not saying that you should go and buy your bike. I'm just giving you this as an option. But I thought that this was a very interesting study. Another study that has been well documented, well described, is the Rocksteady boxing. Okay, as you can see, not a lot of patients, about 31 patients that went into this study, and they compared these to what they call traditional exercise. There was 12 weeks of treatment, several sessions, about 90 minutes for each session. And then they look, at the end, both groups were able to improve in their balance. They both improved in their mobility. They both improved in their quality of life. But the group that was doing the Rocksteady, they have more improvement in their speed of their gait. Even though they both improve in their balance, the patients who were doing this Rocksteady were walking a little bit faster. That time up and go. I don't know if you've heard that term before. The therapies like that. And also they improve their endurance, their stamina. So from there, we have this explosion of Rocksteady all around the country. Even around us, we have 4 places here in Charlottesville, Staunton, Harrisonburg, and then Culpeper. Yeah. So roughly, depending on where you go, somewhere between $50 to $100 a month. Or another way I like to see it is that you can pay about 5.5 years of Rocksteady for the same cost of the bike. But let's say you don't like the bike, you don't like boxing. What other options do you have? And that's when it gets a little bit tricky. There's really exercise for all taste. Doesn't matter what you like. There's chance that somebody has studied that for Parkinson's disease. Their studies are with dancing related to Parkinson's disease. They've done ballroom dancing, Irish set dancing, Zumba, tango, if you are into that. I can tell you all of these studies show some benefit in different measures. There's no one that really stands out above all of them. One thing that I noticed is the Zumba, they didn't actually improve patients. They actually didn't do any better with the Zumba, except that they were happier. So maybe if you just want to improve your mood, go do some Zumba. Yoga is another alternative. Tai Chi, very good exercise. I think both exercise focus on balance, on your core muscles, and getting those strength. Games, virtual reality, that's something that got a little bit of a spike for a moment. Several studies looking into that, and then it started to fade away. I think during the era of the Nintendo Wii and the Wii Sports, everybody got very excited with that and how to use it for like a stroke recovery, Parkinson's disease. But virtual reality, I never thought of that as a good idea. If you have a big headset on top of your head, you don't see your surroundings, and you have Parkinson's disease, I think that's a recipe for disaster. Now you're probably hearing about pickleball, and more recently, one of our therapists pointed out to me that ping pong might be coming with as a exercise for Parkinson's disease. I think that that's nice. I like playing ping pong. Yeah. But like I said, most of these studies are difficult to interpret, difficult to say how much benefit you get. So I always tell, do what you want. That's the best exercise, the exercise that you like and doing. Now, what happens about just going out for a walk? A lot of you, that's the easiest way. You don't need any equipment. You don't need to pay any membership to a gym. You just go out and walk around your neighborhood if you are in a place that has good sidewalks. I know some of you live in farms or hilly areas that can be very difficult. But in this study, looking at different type of exercise, it was 3 groups. One was actually pushing them to walk faster than they would normally walk. The other group was walking at your own pace. Just do what you want. And then the other group, they were not walking. They were just doing a strengthening exercise and a stretching. Okay. And all 3 groups saw some sort of improvement, but each one improved in different ways. So the ones who were doing their own walking at their own pace, they actually had the best improvement in their speed of gait. Okay. So that's a little bit surprising. They thought that maybe the force exercising walking would be a little bit better, but your own pace of walking was good enough. And then strengthening and stretching, of course, improve their muscle strength. They didn't do anything for their walking because they were not walking. And then more recently, we're looking more at this high efficiency, high intensity exercise. So remember that's when you push your heart rate to that 70 to 80% of your max heart rate. And this may not be for everybody, but I thought that it was a very interesting study, very small number. I think it was like about 10 patients, but they look at all of these patients in early Parkinson's disease, and they measure, one, their symptoms, but they also measure how much transporters of dopamine they had in the brain, okay? With a scan that we call the DAT scan. Probably you've heard of that or familiar with that. And we were very intensive, over 6 months of exercise. And you can see they start with some warm up, they do aerobic exercise, followed with boxing, and then they had some cool down time. So a little bit over an hour of exercise several times per week over 6 months. So not only do they improve in their motor symptoms, okay? Sorry, the motor symptoms didn't change, which is usually after 6 months, we always see some progression of the Parkinson, but in 6 months, the motor symptoms didn't change. But most importantly, as you can see there over here, they actually noticed that there was an increase in their dopamine transporters. So the function inside the cells for dopamine was improved in some way with this high intensity exercise. So there's definitely things that we're doing to try to change the chemistry in the brain. And there's now more evidence that exercise is going to have benefits, not only cardiovascular, but cerebrovascular, and that there is production of some chemicals that are affecting directly in the brain to improve not only Parkinson's disease, but neurodegenerative disorders, diseases of the brain. Now, like I was mentioning, what are the challenges that we have? Is that, as you can see, many different things that we can do in regards of sports and exercise. So each study is testing something different, but most of the time they're testing about not doing anything. So when you test something, some sort of exercise against not doing anything, you're always going to come up ahead. You're always going to be winning. They don't want to test against other exercise. They don't want to be on the losing end. Most of the time, these are small numbers. So it's hard to really generalize and say, okay, because this small group improve, it's hard to say that everybody's going to improve. Some changes in the methodology, each study is done in a different way, so it's hard to put them all together to make some conclusions. Some bias that could be inherited. So at the end, if we bunch all of these together, and there's some studies looking into that, their conclusion is that we cannot get to any conclusion. So there's not enough data to say this is the winner or this is something that you should not be doing. Okay. So a little bit in summary, these are the benefits that we know that are coming from exercise, and especially I'm going to point to number 4, which is enhancing cerebral blood flow and oxygenation. And this is something that the earliest you can do that, the better it's going to be for what we call brain health. So one thing that I've noticed is that probably the patients that are doing the best are not only the ones that start doing the exercise as soon as they're diagnosed, but the patients who all their life they've been exercising, they're very active. Because in some way we already start preparing our brains for whatever could happen in the future. From a young age, those patients were already working on neuroprotection, something that I should probably start doing now. But I don't think that there's never a moment that you're too late to do it. Okay. So I think the takeaway point that I want you from today is try to do a combination of exercise. Don't focus on just one thing. And I know that sometimes you patients prefer to just do their exercise at home. I think that there is benefit of going to a class. I do think that there is benefit to going to a class that is dedicated for patients with Parkinson's disease. Because not only you're more invested in going to do your exercise, now you have a support group. You're part of a community, you're part of a family. Whenever you're missing a class, somebody's gonna call you to say, are you doing okay? What happened? Do you need a ride? How can we get you back into your exercise? I don't want you to fall through. So that's what the benefit that I see from doing this type of group exercise. This is from one of the studies that was looking at all of these different research in exercise, and I really like this pyramid. Okay. At the top, you can see flexibility. So who should be doing this? That's for everybody. All the stages of Parkinson's disease should be working on flexibility. How often should be doing it? Every day. That helps to relax some of that stiffness in your muscles. It's going to help you with your mobility, with your joints. Below that, we have what we call neuromotor area of this pyramid. This is your exercise class. This is your rock steady. This is your Tai Chi, your yoga, your pickleball, whatever exercise you choose, the one that you really like, the one that you enjoy. How often you should be doing this? Roughly about 3 times per week. And you can do this at your own pace. And this is the exercise, and this is also for all the stages of Parkinson's disease. Now, the lower 2 levels in the pyramid may be different for each patient, okay? Depending on how advanced is your Parkinson's, you may or may not be able to achieve these. But we have this resistant training. And this is where you want to raise your heart rate to that moderate intensity exercise. There are around 70%, 60, 70% of your max heart rate that I was talking about. This is going out for a walk. Probably has to be a little bit of a brisk walk to raise your heart rate. Maybe going out for a run, using your bicycle. And then at the end, you have the high intensity exercise. That's where you want to raise that to that 85% of your max heart rate, okay? At the end, you want to build up throughout the whole week, on average, about 150 minutes of exercise. And that's kind of should be your goal for each week, that you can say, okay, I've taken my treatment. I've done my part. I'm doing this to fight against Parkinson's, because that's the beauty, that you have the opportunity to do something about your disease. You're not going to be just passive about this. Before I finish, I'm just going to give you a few announcements related to UVA. So as you know, we participate in research in Parkinson's disease. We have a few research going on, and you can always discuss this with your physician. We have for anybody who suffers from freezing of gait, we are recruiting patients who have this problem with the walking in Parkinson's disease. This is to test a new device to help break the freezing. We're going to be enrolling pretty soon patients for a special type of Parkinson's related to this mutation, the LRRK2. So any patient who is very early into their disease, that they're not started medications, those are the ones that we're looking for this study. And the study will do all the genetic testing to determine if you have or you don't have these mutations. So you don't need to know if you have it. It's as long as you have early Parkinson's disease, not on medications, we'll take care from there. So these are the 2 studies that are right now active. We do have some other studies on the horizon, at least 5 more studies going on for Parkinson's disease that we're still working on to see if we're going to be aside. But the exciting part is that 3 of these studies are for diseases that can potentially modify Parkinson's disease, that we can potentially alter the course of the disease. Some of you already know we have our comprehensive Parkinson's disease clinic. This is a multidisciplinary clinic where we see patients with physical therapy, occupational therapy, speech therapy, neuropsychologists. Some of those are right now at the table over there. There's a great team that is working with our nurses and the physicians. And more recently, we just started a new Parkinson's disease access clinic. And this is led by our chair of the Department of Neurology, Dr. Juan, who is a movement disorder specialist. This is for any patient who has not been diagnosed or is transferring to UVA. So new patients, we're going to try to expedite those appointments through this special clinic because we know and we understand also how important it is to start treatment early, to start educating patients early. And we recognize that unfortunately, sometimes our waiting times can be too long. So we have developed this special clinic for Parkinson's disease to get them in and to seeing their physician as soon as possible. So I want to finish with this. This is a quote that was mentioned in one of the studies I was reading that is from 600 BC. And it says, diseases flies from the presence of a person habituated to regular physical exercise. So even at that time, they knew that if you exercise your body, if you keep in good shape, diseases just bounce off you. And that's the concept that I want you to learn, that you can do something about your Parkinson's. You just need to get you moving, or Sarah will hit you. Finally, I just want to mention, if you ever want to support our efforts to help in Parkinson's disease, either for the research or education of our fellows, we have one of our fellows who's going to be talking today. You can contact Jordan Klein, who is our representative there at the university. Their number and email is there in the slide. Thank you so much, and I hope you enjoy the rest of the afternoon.
Don't leave yet. You got question
Oh,
and answer.
Questions and answers.
Yep, so we have about 10 minutes of question and answers. Lauren, who is on Zoom, if anybody asks a question, just raise your hand, and Melissa's going to walk around with a microphone.
About the GATE study, how do you get involved in that?
So if you you can talk to Lauren, who is right there at the front desk. She's our research coordinator, and she can give you all information you need.
I had a diagnosis about 6 months ago, and I'm interested in some of the things you said. How does an individual tap into or get connected with the right sort of programs?
You mean in regards of exercise? How do you get involved with
Exercise. There's LSBT and a comprehensive clinic.
Yeah, so for LSBT is a prescription type of therapy. So your physician would need to write a physical therapy referral for that. All these exercise modalities that I was talking about is patient engagement, is getting out and doing the exercise, getting motivated. And sometimes you might not gonna start doing 150 minutes in the first week. But if you start doing just 5 minutes here, 5 minutes there, and every day you start trying to build up a little bit over that. And the first week you might do 5 minutes exercise. The next week you can do 10 minutes exercise. And slowly you're going to get to those 150 minutes. Joining a class helps you with that.
The research.
The research is something that you can also talk to your neurologist. The comprehensive Parkinson's disease clinic is once a week. We have very limited spots, as most of you already know, but we're definitely discussing it with your neurologist, and they can set you up in the next few months.
I'm going to add one thing, if I may. Through Boston University, there's actually a helpline, if you will, where if you look that up online, I don't know the website, but you can call and talk to a physical therapist, and they can also give you information on exercise classes in your area for Parkinson's.
Yeah. the American Parkinson's Disease Association and the Parkinson's Disease Foundation, they have very good websites, and they have also guidelines for exercise and some exercise that you can try at home.
This information is in our newsletter, so there's a lot of about sport resources, clinical trials information, the programs in Parkinson's disease clinic, all of the newsletter as well. Which there should be a few on all of them.
Questions?
Thank you. Encouraging talk. The challenges slide was about the difficulty of quantifying the difference between types of
Yes.
exercise. Has there been any kind of meta study that really quantifies the effect of exercise in general?
So I pointed out that there's two, there was a Cochrane review, a meta-analysis looking at all of these, and that's where their conclusion was, that they could not make a conclusion. Because
A
of all
conclusion
the,
about the value of exercise in general or specific?
no, the conclusion was based on like, can they say that one exercise is better than the others, or that the one exercise is actually bad and should not be done? And that's a conclusion they got, that they really cannot give any recommendation about any specific exercise because of how all the studies were done and how small each one was. But I think that overall, what we know on the other side is that exercise is good, regardless of which one you're doing it.
Okay.
We have online questions, Lauren? Okay, we were just gonna do an online one here real quick.
Yeah.
Are there any studies on people who do high intensity exercise?
Yes, that last one that I was pointing out was on high intensity exercise, and that's the one that showed some changes on the transporter of dopamine. There was also another meta-analysis looking at just high intensity exercise. And again, similar to the other meta-analysis, basically what the conclusion is, it does work, it does help, but there's no like a specific recommendation of how to do it. I think we have a few over here. You'll be next, John. We're gonna have.
Will there be any effect with lack of government funding for any of these studies? NIH effects?
So those studies that I mentioned that we are now doing, they're either self-funded or industry sponsor. So they're not going to be affected by changes by the NIH, but yeah, that's what it is. I think John had a question over here. You have the microphone.
How do beta blockers change your definitions of exercise and intensity?
That's a good question. I'm not sure that I have the right answer for that, but that is true. Beta blockers are going to affect your heart rate, and I'm not have a good answer. I don't know, Melissa. Do you have any idea? In exercise, do you take a look at their if they're on beta blockers or not?
Yeah, and I think even with Parkinson's in general, sometimes because of all the autonomic nervous system functions, the heart rate might not be as responsive anyway. So you can use a rating of perceived exertion scale, like a 1 to 10 of how hard you feel like you're working. If 10 was, oh my God, I'm gonna die, and aim for like a 6 or a 7 on that. You can also go with a scale of, you don't want to be able to carry on a conversation if you're working really aerobically. You could maybe say a smart, a phrase, but you can't really carry on a conversation with the person next to you on the treadmill. So that's another way you could do it if you don't have a heart rate response.
Yeah, I think just the last thing that Melissa was pointing out, moderate intensity exercise, the exercise that you can still probably talk to somebody, but you don't want really to talk too much. And the high intensity is like, well, definitely you cannot talk to somebody.
Yeah, that's good.
On your exercise pyramid, you state to reach 60 to 80% max effort or 60 to 85. Once you reach that, how long should you hold that?
Melissa, how long should we hold that? Yeah,
Ideally 30 minutes.
yeah. So ideally 30 minutes.
3 times a week.
No, but that's during the exercise. And that's a good question. I actually was thinking about that the other day as I was preparing the lecture. So when you're doing the exercise, you don't need to have all 30 minutes at that heart rate. How much do you have to be at that heart rate?
Usually a warm up until you're getting to about that heart rate, and then ideally you're sustaining that for 30 minutes and then sort of cooling back down afterwards. That's from the American or from the Parkinson's Disease Foundation, their guidelines of exercise. One more? One more? Anything else online?
Okay. Very good. Thank you.
All right, so we have two presentations back to back on your schedule. It lists as one. So what we're going to do is we're going to have Renee go first. She's going to do her spiel. We will not have time for Q&A for that. Then we'll have Lauren go ahead and do hers, and then we'll have Q&A at the end that covers both of them. Okay? Please feel free to use the bathroom as you need to, grab snacks as you need to. We do have like 1 or 2 minutes before we're on schedule. So if you need to do that now, please do that. There are some snacks and waters. Pamela's over there in the green dress filling things up. So if something's low, please let her know. Yep. Stay. See where that camera is.
Okay. All right. Yeah. Great. Give people like 2 minutes.
Yeah. We got about like 2 minutes and then we're back on presentations.
No. Probably Joy should do it. I could go back and do it. I'm just gonna go sit back there. Because I don't want to be like lingering while she talks.
All right, go ahead and start making your way over if you can, back to your seats so we can get back on schedule. So again, Renee's going to talk first. She's going to end her presentation. Then we're going to have Lauren talk and her presentation. And then we're going to have a Q&A session at that point. Okay.
Hello, I'm going to get started because I think I have more slides than I actually have time to present. So a couple extra minutes will be good. I'm excited to talk to you all about what I do for a living. I'm a speech language pathologist. I work in the comprehensive Parkinson's clinic at UVA. And I feel like we're the lesser known of all the therapies. And so I thought, why not give you all some information about what speech pathologists do and how we can help you throughout your journey with Parkinson's. And I thought I would title this talk, but I talk just fine, because that's what people say to me when I come in a room. Like, I'm the speech pathologist. And they're like, but I talk fine. I don't need you. And so I'm going to go over some of the research and things that are up and coming in our field. So what I actually do as a speech language pathologist is I evaluate and treat
swallowing function, motor speech function, and cognitive and language function. All three of these areas can be affected with Parkinson's. And I'm going to just sort of briefly go over each of these areas and sort of what our evaluation and treatment is for them. So the first one, which I think people are maybe a little familiar with, is swallowing disorders. We call that dysphagia, which just means difficulty swallowing. And it can present in many different ways. And for each person, it may present very, very differently. So some people have drooling as a symptom. They can cough or sort of clear their throat while they're eating and drinking. They may have a sensation of food like bread or meats or pills sticking in their throat. They may also just have difficulty chewing the food or moving it around in their mouth. What we know is that about 82% of people with Parkinson's have some level of swallowing problems, and about 50% of people with trouble swallowing don't have much awareness of it. So when there were studies completed where they just tested everyone who's seeing a movement disorders in a clinic, they found, like, on self-report, about 50% of people rated themselves as having no swallowing problems and actually had evidence of swallowing problems on a video fluoroscopic swallow study, which I'll show you what that is in a minute. So that brings into how do we actually evaluate swallowing function? Usually early detection and then repeated evaluations throughout the course of your disease are important. We do some level of screening in the clinic, so I can kind of determine what your risk level is. And then based upon that, we usually recommend the video fluoroscopic swallow study. This study is done in radiology. It's a super easy test. The test itself is like 15 minutes long, and you would eat and drink different foods and liquids that have contrast material in it. And we can actually watch how the structures of your throat move while you swallow. We can see if anything's going down the wrong pipe, if there's any areas of weakness. FEES, which is a flexible endoscopic swallowing study, which is the one on the bottom, is also routinely used. I don't think this is quite as common. We have the ability to do both. And I would say we tend to do the X-ray studies instead. So with the results of one of those studies, we can individualize your treatment for swallowing problems a little bit more. And I think that that's the key. With swallowing problems, there is not, like exercise, just a general treatment that we can give you. Mostly we're doing traditional swallowing exercises that would target the areas that were weak on the video fluoroscopic study. We would give you strategies to help maintain your ability to eat and drink, and then education on how to reduce any risks involved with swallowing problems. Other types of therapy that exist are expiratory muscle strength trainers. These have a considerable amount of research about their effectiveness for not just swallowing and cough, but also for speaking as well. And I'll show you what that looks like in a minute. And then typical therapy that we use for speech, so LSVT, Speak Out, and a Speech 5, all have evidence that they improve your swallowing function as well. So a lot of people will ask about the effects of medication management on their swallowing function. So I think for a long time it was sort of unknown, like, does levodopa help or worsen swallow function? Does getting a DBS make it better or make it worse? We used to, maybe 20 years ago when I first started in the field, we would do all of our swallow studies with the DBS on and with it off and compare the two. And really, I think in the end, what we found was there wasn't much evidence to support that where you are on your medication cycle, or if you have a DBS, that doesn't actually significantly worsen or improve your swallow function. It probably has a pretty minimal effect, if any effect at all, on swallowing. Lots of people will ask about referrals to see an ear, nose, and throat doctor. And in some cases that can be very helpful, but generally there is no like I guess, recommended surgical repair of swallowing problems. They can be helpful for voice issues and for little issues that we may detect on the video fluoroscopic swallow study, but in general, there's no like single medication or surgery they can do to fix swallowing problems. And you know, I think then it leads to, if I'm starting to have more trouble swallowing, sort of what is the next step? And what I have found is that this varies a lot, but that feeding tubes are generally not recommended and not supported in the literature for people with Parkinson's. And aspiration pneumonia, which can be a complication of having swallowing problems, is also not prevented by getting a feeding tube. And so our goal as your speech pathologist would be to help you maintain the ability to safely eat and drink and minimize the complications that could occur. So the importance of swallowing in general is that I think, you know, the disease can cause limited awareness of swallowing problems. And so early detection is key. Doing individualized treatment to target these areas to reduce the risk can be really, really important. The next area we work on is speech changes. People are generally more in tune. This is my favorite meme too in my field. People are more in tune with speech changes, right? Because they may notice a family member, a spouse, a friend telling them like, I can't really hear you. Can you speak up? Or they may notice not the same reaction when they talk to people. So, you know, as our voice fluctuates and as we show emotion when we talk, people will respond in different ways. And with somebody with Parkinson's, where their affect may be a little bit more flat and monotone, you may not notice the same responses from people when you're talking to them. So what we generally do is start with an assessment of speech changes to sort of see what the areas are that are breaking down. Is it articulation? Is it breath support? And then we recommend treatment based upon what we're seeing. So the typical treatments for speech changes are LSVT and Speak Out, which are very similar. I think they both have the same premise and about the same amount of research supporting them. EMST, which is an expiratory muscle strength trainer, which I'll go into a little bit more detail, and Speech Vive, which is a wearable hearing aid that sort of produces the same benefits of treatment similar to LSVT and Speak Out. Along with the research for swallowing, there's also some controversial research showing whether DBS or Parkinson's medications have any effect on speech production. And it seems like the consensus is there's no significant effect. So the three main types of treatment that I would pitch to you if you came to see me would be LSVT or Speak Out. This teaches people to speak louder, to speak more intentionally. It helps build muscle strength in the muscles in your throat, which is why it also helps with swallowing. It sort of recalibrates your perception of loudness, right? So you may not be aware that your speech is a little bit softer than it used to be, and this can kind of help you recalibrate so that you're sort of back to your normal loudness when you're talking. But the downside is it requires continuous practice to keep up your results, just like exercise. If you do therapy for 8 weeks and then you go home and do nothing, you're going to lose any benefit you got from doing therapy. Expiratory muscle strength trainers are relatively a little bit more new on the market, but they have a significant amount of independent research studies supporting their use for Parkinson's. And if you go to their website, you can pull all the articles, which I think are quite interesting. They improve not only swallowing, but the effectiveness of your cough strength and your speech strength. And I think for me is like an easy home exercise that you could do. The cost of the device is about $50, and you could do it for the rest of your disease process, and it would help in many areas for speech and swallowing and breathing. And then Speech Vive is also relatively new, doesn't have as much research supporting it, but I have seen some really amazing outcomes from it. And so for people who have tried LSVT and Speak Out and have not had like lasting effects or lasting changes, it is a wearable, it looks like a hearing aid. It turns on like an ambient noise when you talk, and it sort of, I think, subconsciously forces you to talk louder and slower, and it can sort of provide the same amounts of benefit from speech therapy, but without so much effort involved. So I think the importance when you're thinking about your speech changes is that many people don't always recognize their speech changes, especially their changes in loudness. Speech therapy early on has the best research supporting its effectiveness. So you may think the changes are mild. I'm really not noticing a whole lot of effects when I talk to people, but that is really the best time to start therapy, because even at the mild stages, we can make significant changes, and hopefully those changes will last for a long time. And then continued home practice, of course, is always very important. And then I'm just going to sort of briefly touch on a big topic of cognitive communication deficits. I think because I'm a speech language pathologist, I often think like my biggest goal is to always help everyone communicate most optimally. And it's really, really sad and frustrating for people who lose the ability to come up with the words they want to say, to participate in a conversation that's fast moving. And it leads that person to feel very socially isolated and usually a little bit depressed, right? You're still having thoughts and important things that you need to say and express, but you don't have a space always where you feel safe to do that, or are not allowed the time you needed to communicate what you're thinking. And so I think that a speech pathologist can help tailor your individual needs, help your family cope with some of this, help you feel more confident being able to talk. And so I included this as a handout I give to people in the clinic, but just some common tips for families and friends to make sure you're including a person who may have some cognitive changes in a conversation. So making sure they're paying attention to you, circling back to them in a conversation. So if you're talking about a vacation and we're going to quickly switch subjects and talk about what we're going to eat for dinner, you could circle back and say, hey, you know, we were just talking about our vacation plans before I talk about what we're going to eat tonight for dinner. Do you have anything to add to this conversation? That can be a really important, easy gateway to let the person in their own time and space respond and be part of a conversation. Limiting distractions during a conversation, being patient, you know, using your normal voice and tone, not talking down to somebody when you're in a conversation with them can also be really important. So my final takeaway of all of this is that early intervention is really the key for speech pathology. And I think because of a lot of the areas that I evaluate and treat are not always so noticeable to you or to your family members, it's important to just have a comprehensive assessment. And then if you're interested in doing therapy to get any of these areas stronger, it can be really, really helpful in the long run, especially if started in the earlier stages. So I'm going to let Lauren take over from here. Then I'll answer your questions at the end.
Alrighty. Thank you. And again, just as a reminder, we'll do questions all together with both Renee and myself at the end of this presentation. So my name is Lauren. I'm an occupational therapist at UVA. I work in the Comprehensive Parkinson's Disease Clinic as well. And here today, I'm really just here to kind of tell you what OT is, because occupational therapy is one of those things that you might have been prescribed, you might have come across an OT in your time, you might not have. A lot of times we get lumped together with physical therapy, which I'll kind of talk about a little bit too. And it does make sense. There's a lot of overlap between the two of us, but when it comes down to it, OT as described by our national organization is this quote here. So OT intervention uses everyday life activities, what we like to call as occupations, to promote health, well-being, and your ability to participate in the important activities in your life. This includes any meaningful activity that a person wants to accomplish, including take care of yourself or your family, working, volunteering, going to school, many other things, everything that makes life worth living to you. To break it down from a Parkinson's specific look, this quote really kind of boils it down beautifully, in my opinion. So the role of occupational therapy practitioners in the care of people with Parkinson's is to promote their engagement in meaningful tasks, activities, and roles in their home and in the community. So again, it's really about taking what is meaningful to you, making sure you can do those things, and keeping you as active in those things for as long as possible. So how is it different from physical therapy, right? We need exercise, we need to do this. My doctor told me to go to physical therapy. Well, like I said, there's a lot of overlap between occupational therapy and physical therapy. And I know I didn't have a whole lot of words on this slide for that, but I kind of figured these two pictures kind of sum it up beautifully. As far as OT and PT are concerned, we're both looking at the same picture, right? It's just kind of a different perspective. We have a different approach to get there. So take the map, for instance. We are both starting at point A. We want to get to point B. PT might take one direction, OT might take another direction, but at the end goal, our goal is to make you as independent as possible and to keep you doing the things you love and want to and need to be able to do in your day-to-day. So when it comes to occupational therapy, we consider three parts of a patient, right? We kind of break you down into three pieces, or so it seems. We take your psychosocial needs, things like your family situation, your support. We look at your cognitive functioning, we look at your physical functioning, and separately, all these things just kind of seem like random shapes, blobs, if you will. But from an OT perspective, when we put it all together, we're really looking at the whole person. We're really painting that picture that is you. So our goal is not to focus in specifically on just the physical, just the cognitive, just the psychosocial support piece. It's really kind of wrapping up that picture and making it to where, you know, we're really seeing the full person and the meaningfulness behind what they need to do in their day-to-day. So OT interventions, what this might look like if you are going to see an occupational therapist, they might prescribe you things like exercise or physical activity, similar to like a physical therapist. They might look about your environmental cues or talk about different sort of environmental stimuli or objects or things that can kind of help to make your life a little bit easier. There's also potential for self-management strategies, behavioral strategies, things to where, you know, maybe if you implement these strategies, it might make your life a little bit easier. You're not having to think as much or as hard, or tasks become a little bit more automatic. Depending on where you are in your Parkinson's journey, it's going to look a little bit different. From the early stages of Parkinson's, your OT might be more focused on looking at those self-management tasks, kind of giving you those foundational tools that you can take and build with you throughout your Parkinson's journey. It might look like prevention of reduced participation in those meaningful activities. So making sure to keep you as engaged as possible in the things that are the most meaningful to you, that make life important to you. It also might look like enhancing the activity performance that you're doing. So it's getting a little bit difficult for me to put on my shirt by myself. Let's work on strategies. Let's make that easier for you again. Once we kind of get to the later stages of Parkinson's, that's when we start to build in some more what we call compensatory strategies. So we might shift our focus a little bit based on kind of what's going on in your disease progression. So things like adapting certain activities, or like I said, compensating. So we might be, you know, showing you different kind of equipment that's out there that might make life a little bit easier. We might look at how can we change how that activity that you're doing is done so that way you can still keep doing it. It just might look a little different than the way that you've always done it before. We try to be your problem solvers. We're here, we're your cheerleaders. Our goal is to keep you doing the things that you want to do and making sure that you're able to do all of those things for as long as you would like to. So back to this lovely map that Dr. Fergari showed us. This is the same or a similar study anyway. That just kind of looked at as a whole, and it combined PT and OT together, as a lot of studies like to do. But this just kind of shows you that generally speaking, there is a lot of individuals with Parkinson's in the United States that do not seek the therapy services. And the thing is that comparing us to to the European places, it's clear that there's a huge deficit in the resources that are out there and the utilization of those resources. So the fact of the matter is that both OT and PT is a resource for you. It is something that is available to you, and my encouragement to you is to use it. So kind of the next big question is, well, when do I get OT? When do I see an occupational therapist? And unfortunately, the answer to that is that it truly just depends. Everybody's journey is going to look a little bit different. Everybody's personal experience is going to be a little bit different. For one person, they might not need to see an OT for years and years and years. Another person might want to see an OT right away. It just kind of depends on what's going on in your life specifically. So the biggest things that you want to be mindful of is that are you having impacts to your daily routine? So think things that you have to do every day around the house. Are the things that you've always done and done forever, is it getting more difficult and you're not able to do those things? Do we need to get a little bit of support, just kind of like a mild tune-up, so to speak? Is it impacting your ability to do your household chores or responsibilities? Or what about work responsibilities? Or the most important one that I do like to point out, does it affect your ability to do the things you love to do? Is it impacting your hobbies, the things that you really enjoy? We shouldn't have to give up the things we love to do just because we have Parkinson's and we feel like we can't do it anymore. Let's go find somebody who can help us keep doing those things. And that's the goal of occupational therapy, is really just to keep you doing those things for as long as you are able to. All right. And so now I think we'll do questions for both Renee and myself.
Renee's going to be here. You're going to have the lapel. Melissa has the other one.
I was looking at one of your last slides when you talk about occupational therapy and referral for PT. My wife and I go to the same primary care physician, but she gets referred for PT for her neck, for instance, and the doctor knows exactly what to do about that. I'm not sure that our primary care physician would know who to refer her to for physical therapy for her PD. Is that something that she could come to you for to get? Because you have knowledge of people in the area and you could make those kind of referrals?
So I don't specifically make those referrals. All of the referrals are going to come from the physician. So whether that be the primary care doctor or the neurologist. And then as far as where to go, it does depend on your area. But generally speaking, any clinic that has an adult occupational therapist or adult physical therapist theoretically can treat the PD, can treat the if it's the neck that she's being referred to. The important piece there is that the referral itself generally has the information for what we are addressing. So if it's Parkinson's related, for instance, we would ask that the referral say to evaluate and treat for Parkinson's. So then that's something that I generally encourage people, as far as, if once you have the knowledge that occupational therapy is a resource that is available to you, it is something that you can ask for if you feel like you're ready for a referral. And that can come from your primary care physician, and it can also come from your neurologist. So it doesn't have to be from a specific type of provider, as long as it's a provider that can do that prescription.
Some of the referrals are open-ended, so you don't have to name a place to go.
Exactly. Yes. So yes. So just like he said, for anybody who's online, those referrals are open-ended. They don't name a specific clinic for you to go to. Generally speaking, it's kind of up to you. It's your choice as far as where to go for a clinic. There are some clinics that are going to be a little bit more they see certain diagnoses more routinely just based on this type of specialty clinic that they are. But generally that information is available online for those specific clinics.
Well, that's great.
Yeah.
But I haven't read. What do I? Where do I go? Typically find that sort of.
As far as to find the clinics that do offer that. Gotcha. Yeah, so as for the Charlottesville area, we do have, there's two clinics that both have, specifically from the OT side of things, have a neuro-occupational therapist. Both, there's one over at ACAC, and then of course there's the one that's associated with UVA, the UVA neuro outpatient clinics that are over at Fontaine. But that's for literally just the Charlottesville city area. But in the surrounding, of course, there's going to be more and other options as well.
There is a certified PT Parkinson's therapist at Palmyra at Ivy. So she's very good.
Perfect.
You didn't pay.
Other questions?
Renee mentioned drooling as a possible symptom of a swallowing disorder. Is that drooling in general or when you're ingesting food?
Well, drooling can just be a sign that you're starting to have some swallowing problems. I think, our body produces a lot of saliva throughout the day and we swallow it all day long, right? We swallow it 2-3 times a minute. It goes through our digestive tract. If you're starting to have trouble swallowing, then the saliva will start to build up in your mouth. And then when you go to talk or move, you may have some of it leak out, which would be the drooling. So I think drooling sometimes means that you could be starting to have early swallowing problems. That's not always the case, but usually correlated.
Thank you.
Any other questions for Renee or Lauren? Okay.
Online? Any online questions?
No.
All right. So we are going to be going on a 15-minute break, which means it's 2:42-ish right now. Back in your seats at 3 o'clock. Please feel free to grab some food and drinks. We are running low on water. We have someone going to get more water, but we do have pitchers over there. Or if you have your container, there's a refillable water bottle station around the corner. Please go out and talk to our sponsors. We'll be back at 3 o'clock, ready to go for the next 2 sessions. I forgot to let you guys know that Lisa from APDA sponsored this break, so please make sure you go say hi to her. Restrooms are around the corner on your way out of the building, but before you get to the front lobby. Just giving you about a 5-minute warning, 5-minute warning. All right, folks, we got about 3 minutes, so go ahead and start moseying on over back to your chair. We do have more snacks coming. Thank you, Tyler, for filling them up. We do have more snacks. You guys are a hungry bunch. All right, if you're not in your seats, go ahead and make your way. We do have more snacks and water coming. Like I said, I didn't realize how hungry you guys were going to be. We also do have a lot of food at during the social hour, so don't fill up on snacks. I'm like, eat, but don't eat. All right. If you're not in your seats, go ahead and make your way. Our next presenter is going to be Dana Morrissey, and she's going to do an update on the comprehensive clinic. All right, it's all you, girl.
Hi, everybody. My name is Dana Morrissey, as Sarah said. I'm not Dr. Shaw, as you can see, but he's doing some very important work at home with his new son, and wanted me to send a warm hello to everybody in the room. Anyway, I'm going to do my best to stand in for him and give you a little bit of an overview of our comprehensive multidisciplinary clinic at UVA, and an update for those of you that might have heard this presentation last year. So quickly, I'll just sort of talk about what this clinic is and why we wanted to start it. I actually don't even know why I put these bullets on this slide, because you can tell me better than anyone else why it's hard to access specialty care for Parkinson's and how frustrating it is to navigate the healthcare system. If anybody wants to shout out any additional frustrations, you're welcome to do so while I have this slide up. But the bottom line is it's hard, right? There's online portals, there's passwords and passwords and passwords, there's long wait times, there are phone trees, there are finding the right specialists that work with the other right specialists who work with your insurance. It's a long list, so you know it better than most. The other thing is that the experience of having Parkinson's diagnosis is kind of like a symptom in and of itself, right? There's a lot of uncertainty that comes along with it. Who should I trust? Who can give me the right information? What's going to happen next? What does this diagnosis mean? Whose story in the support group is going to be close enough to mine that I can rely on what they say to think about what might happen to me? How do I advocate for myself? How much is too much advocacy? How do I know who to ask? There's so many things that make it difficult for you to access the information that you need and to get the kind of comfort that you want after this diagnosis and as you live with it, right? It's changing all the time. So we've been working on sort of laying the groundwork for this clinic for a really long time. Why a multidisciplinary clinic? Well, it kind of makes sense, right? That if we put you in one room and bring a bunch of different people that know a lot about Parkinson's disease to you, that would make your care easier to access and easier to coordinate. It's not a big leap there. But luckily the research also sort of bears out that there are some really major factors in affect your quality of life that multidisciplinary clinics are proving to help with. So staying at home longer, if that's something that you want to do, reducing mortality rates, which we all want to do, getting you into rehabilitative therapies sooner, and getting you into the right ones sooner with the right practitioners. Those kinds of things help you manage your symptoms better, help keep severe symptoms at bay longer. So it's not just our idea that it helps to get a bunch of smart people together and let them parade through your room. It's actually it's actually proven that that is a good thing for everyone. So we began planning this clinic in mid 2023, really in earnest. It's like I said, it's been years and years of an idea, and sort of challenging the healthcare system to come along with us. We did a sort of a pilot launch in January 2024, and then a official grand opening in July. And since January, we've seen almost 180 patients. And I think the team would agree that we have learned a lot from each and every person and family that have come through. So again, I just want to talk a little bit more about why we work so hard to make this clinic a reality. We as a team recognize the toll that this illness takes on really every aspect of your life and your family's life, your support network's life. We want you to stay one step ahead of whatever the next challenge is. If it's a decision, if it's a new symptom, if it's a big worry that's come up between you and your family. And I think maybe most importantly, we really want you to feel like we see you for who you are, we hear you, and that we are here for you. And we hope that having a lot of people that care for you compassionately and have a lot of experience with Parkinson's, meeting you all at the same time and then getting to talk all together in our little workroom during and after your visit about the best care plan for you makes you feel like that. So this is something that someone wrote on a survey during our pilot phase, and we only had to pay them $15 to say. opportunity to have people answer some questions for you that might address some worries and uncertainties. Whether you think they're rational or irrational, these are the folks that can help you think through those things. So it's valuable to come even in early days when you don't have severe symptoms and you don't feel like you need it. Am I too quiet? No. Oh, got it. Okay. People that are struggling to manage complicated symptoms. Collaboration between all of these specialists looking through all of these different lenses at once, trying to problem solve about a troublesome symptom is a good thing for you. If you're in a planning mode and you're trying to make decisions about your care right now, you might feel like you need to make a change in who's caring for you or where you're being cared for, and you're not quite sure how to do it. You might be thinking further down the road. This is an amazing team to be able to say, hey, we hear you. We want to know what's important to you, and we're going to help you get there. And again, they're thinking about your situation through all of these different training experiences that they've had and all these different philosophies. And it adds a lot of value to those conversations when you want to have them. Something happened here. Screen. I might have to go back and get my friend. Oh, there we go. Okay, I'm going to brag again, but these are just 2 more quotes from people on those surveys from the pilot period, just to give you a sense for what the perspective of patients and families that have come into the clinic has been. I do want you to know that I'm not just reading these all day long and knowing that we're doing a perfect job and going home and eating my sandwich. We are not just basking in your praise, although we've had some lovely, lovely things said. We have a lot of work to do. We're still planning and thinking about how to improve this clinic and what might be more helpful for you all. If anyone has been to the Comprehensive Parkinson's Clinic, you might know that it's a long appointment. It's long and it's tiring, and you probably get hungry and thirsty and wiggly, and you would rather have left 2 hours before you do. So we're still working on trying to keep that flow moving, keep it as efficient as it can be, and still get the maximum benefit of being with all of these different clinicians. We're also trying to put sort of a more structured advanced care planning support system in place. So if that's something that you're interested in, we're never going to force that on you, but if it's something you're interested in, you have the tools and the people to do it with and the time. Care partners and other people in your support network are vital as to your experience. So supporting them is just as important in many cases as it is supporting you who are living with Parkinson's. If they're not happy, you're probably not happy either. And if they're not healthy, then you're certainly not healthy. So we want you all to be working together, and we want you to all to have the supports that you need. We're also looking or hoping to be able to provide more resources for people that are coming from a greater distance, so the trip to the appointment isn't quite as harrowing or long as the appointment itself. And perhaps you can get some rest and a meal in before you go through the gauntlet. And then we also want to expand the team. There are other kinds of specialists that are helpful for Parkinson's care that most multidisciplinary clinics don't have. So we would be really lucky to be able to have more of these specialists around to be able to consult with us. I also just wanted to say that we will probably be asking more specific questions around these sort of 5 issues if you're coming into clinic anytime soon, to get a better sense for how we can do these things. And we do really try to keep the surveys and questionnaires to a minimum, which I'm sure it doesn't always feel like, but you are unfortunately our best teachers. So we have to bother you for some answers when we're trying to figure out how to do something well. So I'll thank you in advance for taking the time to give us any feedback. And then to close out, I just want to reiterate what our hopes are for what this clinic can offer you. Your quality of life is our bottom line. Our job and our hope is to understand what it feels like to you for you to wake up and start a new day. We want to find out, help you understand. Sometimes it's hard to parse through these questions on your own, but we want to know what is getting in the way of your calm and your comfort, of finding meaning, of living your values, of enjoying your important relationships, all of the things that make getting out of bed worthwhile. We want to help identify those things for you. And then we want to remove the barriers. We want to take all of those roadblocks out of the way, or as many as we can. So you can have meaning and you can have quality of life. And then we also want to learn from your experience to be able to support other people that are going through the same thing. So I wanted to end with this quote just to remind myself to thank you all, anyone who's been through UVA, and I'm sure I would speak for any of your providers that are not UVA based, but it's a real honor for our team to know you and your families. You're a very brave and resilient and generous bunch of people. And we really appreciate you letting us into your lives in the way that you do when you come through. So thank you so much. I'm happy to take any questions. I don't know if I have time for questions. And then I'll just put some information up about the clinic here so you know how to get in touch with us.
I don't know whether this will have any interest in anybody in the room, but it seems to me that one common thread that nobody mentions is the spirituality aspect of what might help to tie a person's overall conditions that have brought them to this point. That maybe another resource for people like that, or who have that need and who recognize that need, that there is some other category that could be fit in there and be available to people.
Thank you for pointing that out. I omitted chaplaincy on that list of providers that we're trying to expand to, but we are in conversations with the chaplaincy department at UVA, who is working really hard to expand their services right now, but they've been in a bit of a shortage. So we have not had a chaplain in clinic yet, but we are really hoping to in the future. Thank you.
Other questions?
I have a question. How many people have been to the clinic? 1, 2, 5. It does. That's more. 15, maybe 15. Yes.
You may have answered this earlier,
Sure.
but do you have to be in your under UVA neurologist to get into the clinic?
You do have to be seen by one of the UVA movement disorder specialists.
So that's sort of a problem, isn't it?
It is a problem if you are not. But Dr. Figari was talking during his presentation about the new access clinic that we have. So that's hopefully going to be a faster track to get into the practice. And once you're in and you've established care with someone that you feel is a good match for you, then we can get you into the Parkinson, the multidisciplinary clinic. Yes. Yes. Uh-huh.
Why bribe him? Or is there another way to do this?
You can call this number and we will put you on a list. You can also bribe Dr. Fagari. I'm sure he's open to that.
And you talked about the fact that this is a synoptic approach that is good for people that are just starting their journey, as well as people that are already
Yes.
pretty far along.
Yes, especially if you're starting your journey and you're in a place where you want to know more and you're finding yourself running up against barriers around where to find good information and how to prepare for the next phase, and how to sort of preempt any kinds of worsening symptoms that you might already be having. Yeah, it's a great place for that. Yeah. Thank you. Oh.
I've been scheduled for the atypical clinic.
Mm-hmm.
Is that the same as multidisciplinary or similar to it?
Essentially. So that clinic also has the same providers. So you also be in the same way. You're going to sit in a room and then all of these wonderful people are going to march through and tell you what they think.
Okay, thank you.
How does Medicare see this as far as what things they cover, don't cover, et cetera?
So I'm not the expert on this, but one of the reasons why it took so long for us to get this clinic started is that you are only billed when you come to this clinic for your appointment with the neurologist. So it would look very much like any appointment that you go to for a follow-up visit. And if you spend a certain amount of time with the neuropsychologist, you get a separate bill for that. But the rest of the therapists are gratis. So the health system has to support their time and their effort without cost to you. It's billed as maximum 2 appointments. So it definitely with your neurologist and then perhaps with a neuropsychologist, depending on how much intervention happens at the appointment. No. No, we run the clinic for a full day weekly on Wednesdays. That would be a lot. Yes. So if your neurologist thinks that, so the question was, what if your Parkinson's disease diagnosis is perhaps changing into Parkinsonism or something that's not PD specifically, then you would be seen in the atypicals clinic for an experience like this one. Yep. So it'd be atypical Parkinson's disease, or atypical movement disorders. Anybody else? Does anyone who's been to the clinic have anything that they would like to share or ask about the experience or comment on? Yes.
I went with my husband
Uh-huh.
and I found it immensely helpful
Oh, I'm so glad.
because it addressed all these aspects that I don't think we actually thought about. And so I think it really helped a lot.
Yeah, I think one of the really wonderful things about it is getting to know the value of all these different disciplines and when you might turn to them later on for help. Yes.
Most of you probably know about, excuse me, All Blessings Well, but they are wonderful. When I called them, felt like I needed a wheelchair, and they gave me this nice, clean wheelchair in great condition. So if you need anything, call them.
Yes. One of the things that we really try to do is help you find resources in the community, whether it's for equipment or for exercise or for counseling, that's another benefit of being in a clinic like this, where you have more clinicians with more contacts and sort of more expertise around where to look for those things. Yes, sir.
Yes, early on when I was diagnosed, I did go to see someone with physical therapy at UVA, and I cannot remember her name, and I don't see her over here today. So anyway, but she was wonderful and really very helpful. So it was over at Fontaine, I know that. And that was very convenient. So it looks like you guys are in town.
We are, yep.
Yeah, a little more crowded.
Yep, we're at the main hospital, unfortunately, for
Yeah.
parking, yeah.
And I would just say I work for MediHome Hospice as well, and we're a bronze sponsor today, thankfully.
Thank you.
And I did my chaplain residency at UVA about 8 or 10 years ago.
Oh, wow.
So probably 10 years ago now.
Are you volunteering to come work in
No, no, but I do think the spirituality needs to be addressed. And so, you know, I wish you well with getting a chaplain from the hospital. But, you know, I'm happy to talk with anybody out here.
Thank you so much. And you raised a good point that I didn't mention before. I think one of the other benefits of seeing one of our therapists who have specific experience in Parkinson's disease is that if they do think you would benefit from an outpatient referral to therapy, they can make very targeted recommendations and collaborate with an outpatient, with your physical therapist that's not based at UVA around your care. So hopefully, even if you're in a smaller town and no one has experience with Parkinson's disease, then they have a dialogue and a coach to sort of help them through caring for you outside of our clinic as well.
You wanted me to mention that it was Janet Dora at, at Fontaine. She specializes in Parkinson's disease.
Oh, that's
so we send a lot of people there.
That's great. Anybody else? Yes.
I would believe that Parkinson's disease, or anyone in your team believes that it is curable.
I do believe it is curable, but I wish I knew on what timeline. We're getting there slowly. Thank you, everyone. All right, so our next presenter actually came from Chicago to speak here. We have Helen Dayton Howard from Rush University, but she is soon to be a UVA faculty member. All right, so you want to use the lapel or you want to stay?
Oh, I can use this. Thank you. All right. Awesome. Yeah, thank you guys so much. I'm excited to come here and talk with you today. I'm also super excited to join the team upcoming in September. So I did my residency in neurology and psychiatry. We call it brain medicine, where we're at. And Parkinson's is like a quintessential brain medicine disease. We deal with a lot of the motor and movement issues for the neurology, but we also deal a lot with problems with the psychiatric aspect as well. So we're going to touch on some of those most common issues when we talk today. All right, and so basically what we're looking at here, mood, anxiety, apathy, and psychosis, many of which you're probably already familiar with, you guys who are here with me. So first of all, depression or changes in mood. This is a very common problem in our Parkinson's disease patients. And this can start even before we have problems with movement in Parkinson's disease. So like constipation, anosmia, and issues with RBD, we can see depression years before we get any tremor, stiffness, or slowness. So very common issue. And a lot of our patients will deal with this. So about 35% of people with Parkinson's disease at some point will be dealing with some of these symptoms. And there's been a couple of theories about how this actually comes about. Initially, when we were discussing this many years ago, it was a thought process that it's a big life change when you develop Parkinson's. You lose the ability to do a lot of things you may have been able to do before. You know, you have to change how you're working, how you're living in your community. And so initially there was some thought that maybe it's an adjustment process. And I think that that is still true to some degree because it is a big life shift, but there's also some pathologic changes that we see as well that come along with the actual disease of Parkinson's. And it's also a lot more than just feeling sad or low or down about how you're doing. So it's also issues with our sleep, with not wanting to eat, low energy, trouble with focus, and even thoughts of self-harm. And we'll talk a little bit more about that at the end as well, about things we can do to help with that. And so if you're having these problems, it's very important for you to talk with your provider because there are a lot of things that we can do to try and help you feel better. So we need to make sure that you're letting us know. And one of the things that they talked about at the very beginning, exercise, is really, really important, and that can help lift your moods. So you might want to go out and get into one of those Zumba classes, as I had mentioned earlier. So that would be great. Trying not to isolate, even though that's easier said than done, finding ways to be social, engage with the Parkinson's community is really helpful as well. You know, and then spending time with your family, with friends, with all of my patients love their grandkids, which is always amazing. They have the best pictures. So, you know, being involved with that is really, really good. As much as you can, try and keep up with activities that you enjoy. So you may not be able to do everything to the same degree that you always could, but trying to find ways to stay involved in those activities can be really, really helpful and can be another way to lift your spirits. So staying busy. And then working on keeping your sleep as regular as possible, trying not to nap too much during the day. I'm guilty of that sometimes too, so I get it. But we want to try and sleep as much as night and stay up and active during the day as much as we can. And then lastly, when a mood gets really bad and we're struggling a lot more, seeing talk therapy can be helpful as well. And a lot of what people think about when they hear talk therapy is like laying on a couch, free associating while someone is probably doodling on a pad behind you. But that's really not what therapy looks like now. It's much different than it used to be. It's much more engaged and much more of a discussion. And then especially helpful for our patients is a type of therapy called cognitive behavioral therapy, and that helps us work on some actual skills to help manage mood, manage other symptoms. And again, that's very directed. So those are other ways to get better support. And then medications are another common way that we can manage symptoms as well. SSRIs are the most common medications that we use. And so this includes medications like sertraline, fluoxetine, and escitalopram. Those are probably the top ones that we find ourselves using. And they boost a chemical called serotonin, which we think helps boost and lift mood. Generally, these medications are very well tolerated. And don't have significant interactions with our Parkinson's medications, so those can be really helpful. One of the things to keep in mind, though, is that all of these medicines take like 6 weeks to work. So we want to wait it out for a little bit and give them a chance to kick in before we kind of drop them and give up on them. So there are some other medicines that we try as well. There's a medication called mirtazapine or Remeron. And what's nice about this medicine is that you have trouble sleeping. It can help you sleep better at night. And it's really good for our patients who have problems with their mood where they don't sleep and don't eat because it boosts your appetite too. So it can help with multiple different symptoms. And then sometimes patients with low mood and low energy do well on a medication called bupropion as well. This medicine also boosts up dopamine a little bit, so that can be kind of a nice bump for our patients with Parkinson's. So lots of different things that we can try to kind of make things a little bit better if you find that you're struggling with your mood, okay? Next, anxiety is another extremely common problem in our patients with Parkinson's disease. People find that they worry a lot more. They may ruminate on things and may even have trouble doing things that they normally do because they're feeling more nervous or anxious. And panic attacks where you feel like you're kind of losing control, you're very, very anxious, your heart's pounding, can occur more as well. And then one thing you need to be aware of in Parkinson's is that it's a big problem with some of the ups and downs of our medications. So it's not uncommon for patients to notice that when their medications wear off and kind of go away, that anxiety really starts to pick up and that they get a lot more nervous. So this can be really difficult for you guys to manage. So we generally try and make your day smoother by balancing out the Parkinson's medications and also potentially trying other medications for anxiety to help calm things down a little bit. So other things that we can do for management here, again, you're going to hear a lot about exercise today because it's one of our biggest talking points in Parkinson's, but it can also be very, very good for managing anxiety, and it can help get your head clear and calm you down. There's also other things that you can do to relax to kind of calm that anxiety down as well. So reading, meditation, Tai Chi is really good for this. I've heard you guys have some really good yoga classes here. That's really awesome for that as well. So figuring out ways to kind of take down that excessive activity and cool down is really useful. If you're noticing that you're having a lot of those ups and downs, especially if that's triggering some of the anxiety when you're feeling more off, you should talk with us about trying to adjust some of the medications and seeing if that can make a difference too. And then, like I mentioned before, talk therapy is another really useful intervention. And cognitive behavioral therapy is the primary kind that we do more for anxiety as well. And that's nice because it can help you recognize when you're starting to feel more nervous and more anxious and give you strategies to kind of calm that anxiety down and get yourself back on track. So some really helpful things there. As far as medications, these are very similar to with mood. So SSRIs are some that are frequently used. SNRIs, which work on serotonin and norepinephrine, also are used actually for both mood and for anxiety. Venlafaxine has had good evidence in previous studies for both mood and anxiety and Parkinson's. Duloxetine is another nice medication in that group that we can use as well that can be really helpful for anxiety. There are some things that we don't do because they can cause more problems with thinking, with confusion, with falls. So we generally avoid medications like Benadryl that can make you sleepy or sedated. I took a Benadryl once and I think I slept for like 4 hours in the middle of the day. So not necessarily the best idea. And there are other medications that can be more habit forming that are okay in younger patients in smaller doses, but we try and avoid them as much as possible in our patients when they get up there a little bit in their years, okay? So things like lorazepam and alprazolam can increase the risk of confusion and falls, and you can get kind of dependent on them. So instead of being able to find ways to kind of calm yourself down, it's easier to take a pill and get in that cycle where you're stuck taking those medications. So we really try and avoid those. Clonazepam is kind of the exception because we use that at night for our patients who have REM behavior disorder. It can be really helpful for that. So you might find yourself using that at night, but during the day, we try and avoid some of those other types of medicines. And then next on the list is apathy. This is another really common problem that I feel like doesn't even get talked about as much as depression and anxiety in our patients, though I get this complaint all the time from patients and families. So this happens when patients really don't feel like doing much of anything. They don't much have motivation. They want to just sit at home. They're like, I just want to watch TV. I don't really want to go anywhere. And it's different from depression because when patients are depressed, they're feeling sad, they're feeling down, they feel crummy. But patients who have apathy are just like, meh, I don't really want to go. I'm happy to just sit here. Once you get people out of the house who have apathy, they might find they actually enjoy themselves. So you might say, hey, let's go get dinner with our friends. And they're like, meh, I don't really want to go. I just want to sit at home. But if you drag them out and get them to dinner, then they're actually enjoying themselves and happy to be at dinner. So we can see that as well. And I'm sure that you guys are who are dealing with this are aware, it's much more frustrating for caregivers than it is for patients usually. The patients don't mind because they're fine with it. They don't mind sitting at home, but spouses or caregivers who want to get the patients out and want to do things and want to be active, it's a lot harder because they feel like they have to work a lot more to make that happen. And the other thing that we have to watch out for is not having this motivation makes it difficult to do the things that we know can make our disease better. So it can get in the way of going to therapies that might be helpful to keep your walking more steady, to keep you functioning at a better level. It can keep you from exercising like you might be recommended to do. So very common problems. And this is difficult to treat. We have a couple of things that we try. We sometimes try stimulants like modafinil and methylphenidate to try and really kick people more into gear. It's varying levels of success depending on the patients. And the biggest thing that we wind up doing is a lot of counseling with you guys to try and figure out a good balance. It is frustrating for sure. We want to make sure that we have a little bit of leeway with those activities, but we also want to make sure that you guys are working together on a schedule during the day to make sure that you're staying active and that you're doing things that you need to do. So trying to find that balance between pushing to get patients out and doing things and not kind of getting too on top of things is helpful. And it's important to know that apathy is not being obstinate and is not purposely being disengaged. Those pathways that drive our motivation and those pathways that drive our need to do things just don't work as well in some patients with Parkinson's disease. So it's something to keep in mind that can also be difficult to manage. And then lastly, psychosis is something that usually shows up later in our Parkinson's disease patients. In our patients with dementia with Lewy bodies, we see it much earlier in the disease. But for general idiopathic PD, we're talking maybe like 10 years on or so, and we really start to see more of this as an issue. Most commonly, patients have hallucinations, usually seeing people or animals. And so I've had patients tell me a wide variety of things. Patients have told me that they see little people in the house, they see kids playing, they might see family members. Sometimes they see pets that they had when they were kids, or other types of animals as well. And then instead of some of the other psychiatric disorders where people hear more voices talking to them or talking directly at them, auditory hallucinations tend to be more that they're hearing voices in another room, music in another room, might think the TV is on when it's actually not. So it's a little bit different from what we tend to see in our primary psychiatric patients. And these can start off really mild, a little bit earlier than the 10 years in disease as well. So really mild hallucinations can include what we call passage hallucinations. So that means that patients see movement out of the corner of their eye and they look and there's nothing actually there. Or presence hallucinations, where patients are in a room and they feel like they're not actually alone, like there's a figure or a person in the room with them. Sometimes you might see a shadowy figure in the room with you as well. It's not really well formed. Generally, at this point, patients really have good insight and they know what's going on. So they'll tell me that they see these things and they're like, I know it's not real. I can tell that it's not a problem. Other things that can present earlier on as well are called illusions. So that's mistaking something for something else. So they might see like a bush in the yard and think it's a cat or a dog or something like that. And usually, again, with those things, people have pretty good insight. They know that those things aren't real. The other type of psychotic symptoms that we can see are delusions. So paranoia, thinking people are imposters, people thinking that they're dead, less common, but can happen. More so on like the paranoia and thinking people are imposters side of things. And this is really distressing for obvious reasons for our patients and our caregivers. So these symptoms are something that we want to make sure that we're talking about and we're addressing. And this is something that we see, and we want to make sure that you guys feel open and able to discuss with your providers when that's happening. So treatment can kind of vary, and it really depends on how bothersome the symptoms are. So the first thing that we try and do is if you're reporting some of these things going on, we want to get ahead of it. We'll try and simplify some of the Parkinson's medications first. So taking away some anticholinergic medications, getting rid of the amantadine, getting rid of dopamine agonists, other things like that. Levodopa is always the last to go, because that actually has the least risk of causing these symptoms. And if you're having issues with like memory and thinking that come along with the hallucinations, we can try medications like donepezil or rivastigmine, because those are actually really helpful for treating both memory problems and visual hallucinations. So we use those quite a bit. And if we absolutely have to, there are a couple of medications that we can use targeted at treating hallucinations. And the most common one you guys will probably see is quetiapine or Seroquel. And that's usually given at night. It can help also with sleep. Pimavanserin is a medication that we can use that's actually designed for Parkinson's disease psychosis. The one thing to keep in mind with that is, like some of the other medications, it also takes about 6 weeks to work. So we want to give it that time to sink in. And then in cases where we're dealing with either maybe more agitation, more significant hallucinations, we may use a medication called clozapine. It works really, really well at really low doses, but usually we reserve that for more difficult to handle symptoms. So some of the takeaways that I wanted to give you is that all of these things are common in Parkinson's. You know, we want to make sure that you're aware of them and you can watch out for them, and that you should be able to talk with your providers about these issues when they come up. So we want to make sure that we're taking care of the whole person. And it can be it can lead to a lot of stress and a lot of other issues as well. But a combination of lifestyle interventions, therapy, and medications when needed can be really helpful to get these symptoms doing better. Again, apathy is common, more frustrating for the caregiver than the patient, but you know, we want to make sure that we're talking about that as a problem and finding other behavioral interventions to improve that. Psychosis occurs later in disease, and then medication modification and potentially use of antipsychotics can make those symptoms more manageable. And then lastly, the biggest takeaway that I want to have from this is that if you are having any trouble or thoughts of self-harm, you know, we want to make sure that we're having an open dialogue with our patients about those things. And if that comes up, there are many resources that are available, and I want to make sure that you guys are aware of those. So 911, obviously, we all know. And 988 is the new crisis hotline. So that's important. And that also gets you in touch with Virginia Mobile Crisis, and they can come out and help you as well. There's a crisis text line. For any veterans in the room, 988 also connects you to the Veteran Crisis Hotline. And then presenting to the emergency room is also really important too. So, you know, we want to make sure that we're addressing all these things as far as safety is concerned. And, you know, we're here as a team, and we want to be here to support you, okay, with all these things going on. Thank you so much for having me. I'm really excited to join you guys in a couple of months. Any questions that I can answer?
With anxiety, I find the only time that I'm anxious is right before I'm due for another dose of CL. So and then once I take it, it totally disappears. So I'm just wondering how you decide when is the right time to go on either up your medication dose or go on something to help anxiety.
Yeah, that's a great question. So at that timing, it might be that that previous dose might be just wearing off, like you're saying, before you're due. So either if it's bothering you enough, we could either try and change the CL dosing a little bit if it's consistently a problem, or if it's just in general bothering you, then we might try an additional medication like an SSRI. But I think if it's more specifically tied to that timing period, it might be worth seeing if you could bring your dose a little bit closer together. You could talk with your provider about something like that. So I think that that's one of those instances where if you are like, I'm totally fine the rest of the day, and this is just that time period, then that might be more of addressed by a CL adjustment. So just a consideration.
Yeah, thank you. I think based on what I've read, I've concluded that medical marijuana is not helpful to Parkinson's patients. For mood-related issues, I'm just wondering if you would concur with that.
Yeah, so I think that from what I've read also, I would concur with that as well. I think that my other concerns with Parkinson's is, increasing risk of other psychotic symptoms, increasing risk of falls. So I feel like, the other, because I do get asked about that a lot as well. I think the other issues that we could see come up with that, probably the risk isn't worth the benefit. And I don't think that we've seen enough benefit to make me think that this is a strong recommendation.
First of all, I don't have a bit of trouble sleeping, so it's not the medication. But I do take the Covry, and they tell me to take it at night. And if I miss a dose, then my legs really bother me the next day. And also, I take Lexapro, and that was prescribed for me to take at night. But you said it kind of lifts you up, so should I take it in the morning?
It's a 24-hour medication, so it just kind of depends. I would talk with your provider about changing up any times because but I don't think that, one or the other would make too much of a difference. Sometimes people do notice that SSRIs make them a little bit more wired and jittery, so it could be worth trying to talk with them about changing the times.
Okay, thank you.
One of the things I find when we're both, not just him, me as well as a caregiver, really uptight about whatever, I try to keep the house really calm and I always have music on. And that kind of just brings us 2 levels down. And then we kind of do our thing, but we watch the news twice a day. Otherwise, it's off. Well, lunch and dinner, but really
Yeah.
Music really, I'm just talking low key.
Yeah. Yeah, so I think, we've had some good studies about, music and things in general being very helpful. And, one of my friends actually in residency who was in psychiatry was doing a project or working with patients to have like an app where they could go back and listen to music that were more familiar from when they were younger. So like, especially for patients with more memory issues, that seemed to really help behaviorally. So yeah, anything that kind of keeps people, like more even, more, happy. It's like, music is just awesome for that. So
Our grandkids come up, they don't say anything, we just know, oh gosh, that's
yeah. So no Taylor Swift.
There's a video series called Mindfulness Mondays too, which I can't remember if it's through the APDA or the Parkinson's Foundation, but little videos you can tune in and do some mindfulness.
Hi. Do you have any thoughts about psychedelic assisted psychotherapy for depression or existential dilemmas?
That is an excellent question. I can't speak necessarily for Parkinson's specifically, but I know that we're doing a lot of research in that area in general. I know some people out on the West Coast are doing a lot of that, and I think that it depends on the situation. So if you're going to a clinic where they're actually doing talk therapy, I think that, it can be useful. There's some other places that they just kind of give you psychedelics and they kind of leave you in a room. Probably not as helpful. But so I think but I don't know any evidence yet for Parkinson's specifically. So I think that's to be determined. But I think that in the next couple of years, we're going to be seeing a lot more of that in general in psychiatry, and especially for like trauma related situations and things like that. So I think that that's going to be even more of an upcoming thing.
Thank you.
Excuse me, sir.
Thank you. most of your solutions are medicine related, med related. I was wondering if you do any stem cell work in terms of like the Energy for Life Center out in Utah that Dr. Echo proposes. And he does Echo protocol with song lasers, and he publishes in this Journal of Stem Cell Research and Therapeutics. I was wondering if you all do any Chinese medicine based analysis on curing the disease rather than just treating it with meds.
Yeah, that is a really good point. I know that historically we've done some research in Parkinson's in general in the past regarding alternative treatments like stem cells. Previous studies have not borne out, but I know that we're revisiting that, like you said. As far as specifically for mood and anxiety, I don't know off the top of my head. I'd have to go back and look. But I know in Parkinson's in general, we are looking more into that. So we're circling back around, and it is really, really interesting. I'm interested to see what the results are going to be.
Okay.
Online
One,
first? Renee, no. One more?
anyone more?
Questions or you're trying to get out?
I'm going to go out for my pill alarm.
You have 4 minutes until it goes off.
Yeah. All right.
That's
Thank you so much.
All right, so we have one more break. It's 15 minutes. If you guys decide that you're ready to come back before the 15 minutes, that means we could have a longer social hour. So just FYI on that. Please go see Trey and Sadie. I didn't know Sadie was coming today. So Trey and Sadie from Boston Scientific are the ones that are doing this break. So go have 15 minutes-ish or so. We'll come back 10, 15 minutes. All right. Yeah, Trey and Sadie are right across the hallway with Boston Scientific. All right, we got about 4-ish minutes. I think we're gonna try to get ahead of schedule. That way we can have a little longer social hour. So throw your trash away, grab an extra snack, make your way back to your chair. All right, about 2 more minutes, and then we're gonna add a little time and get started. All right, let's go ahead and find our, ooh, Tom Lincoln, that's number 2, you've done that. All right, go ahead and find your seats. We have another presenter. So we have 2 sections left. We have this section, which is gonna be next, and then we'll do question and answer. Our last section of the day, we're gonna actually have 3 presenters back to back to back, okay? And then we'll have a social hour. All right, so we'll shut these doors very soon, but our next presenter is going to be Dr. Philip Lee, who is UVA Neurology. Come on over. He also presented last year, for those who remember.
All right, thank you. Thanks everybody for coming out. This is a lot of people. This is exciting. I'm going to ask a question. I asked this at a recent talk, but I kind of want to get the feeling for this room. So, how many of you, when you say Parkinson's disease, do you say Parkinson's disease or do you say Parkinson disease? Do you put an apostrophe or make it possessive? If you make it possessive, raise your hand. If you don't make it possessive, raise your hand. Oh, it's the minority. I realized my own presentation is actually mixed today. You're not wrong either way. The convention for a long time has been to put the apostrophe. A few years ago, the American Medical Association editor, somebody like that, I don't know who they are, they said that we should take the apostrophes out of all named syndromes and things. So officially, a lot of publications have moved to Parkinson, but you'll still find it mixed. I'm slowly moving towards getting rid of the apostrophe, but I did not succeed in this talk. I can see on my title slide here. I just realized that. You have to be careful with it, though, because if you don't put the apostrophe, you have to make sure that you say disease after it. So Parkinson disease. It's going to be confusing. You might get some strange looks if you go home to your family and tell them that you're living with Parkinson. All right. Anyways, we'll get started. All right. So Parkinson disease. So what is Parkinson disease? So what we actually know about the disease is that you lose neurons or brain cells in this part of your brain called the substantia nigra. That stands for black substance. That's the part of your brain where you produce dopamine. We know that there's then dopamine dysfunction in another part of your brain called the striatum. If you see that picture up there, on the left side is a normal brain that's lighting up in the striatum where dopamine's functioning normally. And then on the right side, we see the two dots. Dopamine is not functioning normally. That's what a DAT scan looks like in Parkinson's disease. And then the other thing we know about it is that there is usually alpha-synuclein, this protein, that abnormal versions of it aggregate and form these things called Lewy bodies inside of neurons. And that's what that picture, that pink picture on the very edge of the screen is. Okay. This all leads to the syndrome that we know and that was characterized by James Parkinson over 100 years ago. Over 200 years ago, I think at this point, which we know as slow, small movements, muscle stiffness, and tremor, and specifically rest tremor when you're not using your hand for purposeful activity. Parkinson's disease starts long before those motor symptoms, those characteristic motor symptoms that we know of. It actually can start as much as 30 years before people first notice those motor symptoms. So if you look at this picture here, that big blue line is the number of those neurons that you're losing, the number of those dopamine-producing neurons that you're losing. If you look about halfway across, you'll see that little red line going up. That's the motor symptoms that we just mentioned in Parkinson's disease that start going up. So it's somewhere when you lose half or more than half of those brain cells that you actually first start to see the motor symptoms of Parkinson's disease. There's also many other non-motor symptoms. There's a bunch of them are listed up there. They don't necessarily present in that order or that timeline. It can be kind of mixed, but those are some of the non-motor symptoms that people might experience. All right, so what do we do about Parkinson's disease? How do we treat it with medications? There's two approaches to medication. One approach is to treat the symptoms of the disease itself. That's what we call symptomatic therapies. The other approach is to treat the disease, to try, as some people have mentioned, cure the disease or slow the disease or stop the disease where it is, something like that. And that's what we call disease-modifying therapy. So if you look at this wheel that gets produced each year, it just looks at drugs that are in research for Parkinson's disease. The vast majority of them fall under the disease-modifying therapies category, and well, not vast, but the majority fall under that category, and a lot of them just fall under this symptomatic therapy. As far as therapies that we currently have available, they are all symptomatic therapies. There are no disease-modifying medications that are approved by the FDA right now for Parkinson's disease. We heard earlier about how exercise can have some role in being disease-modifying and slowing the disease, but right now there's no a pill that is approved to do that. All right. The kind of main focus of this talk is going to be on the most common medications in Parkinson's. As you saw from this slide, there's so many medications that we can use, and you can get into all these the symptoms that are above the green bar there. And the number of medications that we'd have to talk about would be really vast, and we don't really have time for that. So what I want to talk about is dopaminergic medications. So this core feature of the disease is you lose these dopamine-producing neurons. You have that dopamine dysfunction, and you have these motor symptoms. So most of what we're going to be talking about is the medications that treat the motor symptoms of Parkinson's and trying to understand those medications and how they work. So I'll get into that here. All right. Everybody knows carbidopa-levodopa. Other names for it are Sinemet, levodopa, levocarb, and co-caroldopa. Other things that people might choose to call it, carbilopa, lopadopa, that one with the long name, and I have one person that chooses to call it Oompa Loompa. All right, so we're going to have some Oompa Loompas for levodopa that are going to join us for this talk. So that's our first Oompa Loompa holding up a tablet of carbidopa-levodopa for you. All right. So what is carbidopa-levodopa, which is kind of this gold standard medication that we use for Parkinson's disease? So it's two medications in one pill. The real medication is the levodopa. That is replacement dopamine for your brain. So once you take the pill, it has two medicines in it. The levodopa gets into your bloodstream and then goes to your brain. Once it's in your brain, it gets converted to dopamine, and it replaces that dopamine that your body doesn't make anymore, restores some of that function that is abnormal in your brain. Now, if you took levodopa by itself, it would make you really nauseous and wouldn't help you move because, well, it would help a little bit, but not very much, because most of it would get broken down in your body, and once you have the dopamine in your bloodstream, not in your brain, it causes nausea instead of helping you to move. So that's why there's a second medicine with it called carbidopa. That carbidopa slows down your body, breaking it down, so the medicine can get into your brain before it gets broken down. So the carbidopa helps the levodopa to work better and cause less nausea. So that's why there's this long name, these two medicines in one pill. So what does it do? Once this gets into your brain, it should help you to move bigger, to move faster. These are our Oompa Loompas moving big and fast, running away from the, that doesn't look like a chocolate factory, but that's what AI put back there. So that's how the robots are going to make chocolate in the future. Anyways, it may help your tremor. So a lot of people, they take a pill and the tremor goes away. Some people, it doesn't do anything for the tremor, and it may help other symptoms of Parkinson's disease. It's a little bit less predictable for most other symptoms. As far as side effects, like I was mentioning a second ago, the most common one is going to be nausea. That's very common. And then you can get motor complications or dyskinesias. Those are wiggling movements. That makes sense. If you have a disease where you don't move enough, you take a pill to help you move more. If you take too much of it, then you move too much and you wiggle a little bit, and that's what we call dyskinesias. Other things that are kind of rare side effects, or not necessarily rare, but less common side effects, can be sleepiness after you take it, drops in your blood pressure, hallucinations, or at high doses, you can potentially get impulse control disorder with it. All right. So how does levodopa work? So here's a graph. This is a single dose of levodopa. So that where that arrow is pointing, that's where you take the medicine. When that black line goes up, that's the medicine going up in your bloodstream. and then it comes back down over time. All right. The medication has to reach a certain level before it has an effect. So that second blue line, once the medication gets to that level, that's when you start to notice benefit, or what would say it kicks in. You start to feel it. So you take the medicine probably about 30, 45 minutes, somewhere there, before you start to feel it kick in. Then it keeps working better for a little bit longer, and then it's working its best. That's probably about 90 minutes to 2 hours into your dose, somewhere around there, and that's what we call peak dose. And then it starts wearing off. And then there's a point where it goes back down below that blue line, and that's what we call wearing off. So these are probably questions that you get asked by your neurologist a lot of times when you're talking about how you want to adjust your medication. So this is kind of how a single dose works. You have to take it, it gets in your bloodstream, has to reach a dose before it works, and then it wears off. That amount of time that it works is probably about 3 hours up to maybe 5 hours for some people, but 3 to 4 hours is probably more common. Very early in Parkinson's disease, a lot of people will take this. It works really well. You get 3 hours. They give it to you 3 or 4 times a day, and you space the doses right, and it keeps you covered throughout the day. You don't really wear off before the next dose kicks in, and don't really have side effects very early on. It can work like this. Now, as Parkinson's disease progresses, the amount of medication that you need to treat your symptoms increases. I had an animation here. I don't think it quite worked. That blue line is supposed to go up higher and show that you need that higher dose. You got to get to a higher bar before you get effectiveness. And so if you have to get to that higher bar, you often increase your dose at that point so that you can kind of maintain the same amount of benefit. All right. When you increase your dose, eventually you get to a point where you're going to start getting these side effects of the dyskinesias, the motor complications that we call them, that wiggling movement. So what you really want is to be in between those blue lines when the medication's working well and not causing those dyskinesias. And this is often what we're working towards when we're adjusting medications in clinic. So this is where you want to be, like this. So you want the dose to be enough, but not too much. All right. So as Parkinson's disease continues to progress, that window gets smaller and smaller and smaller as you go along, and you have to then maybe lower the dose a little bit more to not have the side effects. And then if you want to keep your coverage and not have gaps where you're wearing off between treatments, what you would have to do is take small doses very frequently. And if you get to this point where you're taking like a dose like every hour, every 2 hours, trying to keep yourself right at that steady level, it becomes very difficult. This could be like a full-time job. You need a secretary for this. And so here's your Oompa Loompa secretary to help you manage these frequent small doses. This is not what anybody wants. So we have other solutions for this problem, right? So nobody wants to take these frequent small doses of medication. This can really affect your lifestyle, and it's not where you want to be. This is kind of a variation of the same graph. So over the course of the disease now, that window where we can treat your symptoms narrows. Does it narrow because you started taking carbidopa-levodopa too early? That's a question we asked for a long time. Should we delay treatment? The answer to that is no, we should not delay treatment. So they actually did a study looking at this. They took a lot of people freshly diagnosed with Parkinson's disease that were not taking medication, and for 40 weeks, they gave half of them carbidopa-levodopa, 1 tablet 3 times a day. The other group, they didn't give it to. And then at 40 weeks, they started giving them all the same thing. So the group that didn't take it had more symptoms and more disability during that first 40 weeks where they didn't have the carbidopa-levodopa treating their symptoms. And then when they started it with everybody else, they merged into the exact same line there at the end of that graph where they were exactly the same, whether they had delayed starting it or not. And we kind of use that as evidence to say that you shouldn't delay starting it because it's going to have some more effectiveness later. We don't believe that that's true. If you need it to treat your symptoms, it's best to just start it when you're ready. All right, so back to this same graph again. So we're going to look at some ways that we can stay in this window. I'm going to switch this graph up a little bit. So now, if you look at it, that black squiggly line is your dosing. That green area is what we call the therapeutic window, where you're treating your symptoms but not having side effects. The gray is Parkinson's symptoms, and the red is side effects of treatment, the dyskinesia. Okay, so how can we fix this issue that we have with the medication where it doesn't last long enough? So there's extended release versions of carbidopa-levodopa. The older one of these is carbidopa-levodopa extended release or continuous release tablet. We mostly use that one at nighttime because it's very inconsistent. When you take it during the day, you can get all of it at once. You can have a delayed onset. So if you take that one during the day, you often don't get a nice steady level with it, even though it does last longer. A lot of people will use it and mix it with the immediate release if they use it during the day. That's a very common way to approach it. There's some newer versions of long-acting carbidopa-levodopa. So these would be the continuous or extended release capsules. Sorry, I have the wrong caption there on the side of that. But the second one should be capsules. So those are the drugs that are like Rytary, Crixant, where they actually have little beads that release, and it's much more steady in how they release. They're very good medications, but can be very hard to get. And they might end up lasting, 5 or 6 hours instead of 4 hours somewhere. So can definitely provide some more length, but still not perfect. And so what that does is it basically extends the time for it to that blood level to come down of the medication, so you can spend a little bit longer in that green window. So that's one option for addressing this issue of the short dose duration. And then there's medications that extend the effectiveness of your normal carbidopa-levodopa. So these are the medications that we call COMT inhibitors or MAI inhibitors. So medications like entacapone, tolcapone, opicapone, all those kinds of medications. Those ones particularly, you can see right there, stop the breakdown of dopamine before it gets to your brain. So your body breaks it down slower and it lasts a little bit longer. The MAOI inhibitors, they are right over there. So actually in your brain, it stops the breakdown of dopamine and can last a little bit longer. So those are medications that you might use along with levodopa to make your dose last longer and have the same kind of effect as the longer acting levodopas, but with those you have to take another pill. So that's one option. Another way that we can kind of make this therapeutic window work better is use medications that treat the side effects. So we often use a medication called amantadine that was actually created for the flu, but people with the flu, their Parkinson's symptoms got better, and now it's probably mostly used as a Parkinson's med and some in psychiatry as well. So it actually extends the amount of time that levodopa is in the brain cell available to be used. So it can actually provide a little bit of treatment to your Parkinson's symptoms. And then it has a second, what we call mechanism of action, the way it works, where it works on these other receptors in your brain called NMDA receptors and can reduce the dyskinesias that you have. So what this would look like is that when you take amantadine, it increases that line before you hit the dyskinesia. It may allow you to use more of the levodopa without the side effects. So that's one way that we might adjust your levodopa therapy. Another option that's available is inhaled levodopa powder. So this is the, you can see the inhaler there. You take a little capsule, put it in there, and you can actually breathe the levodopa in. What this does for you is it basically gets the levodopa in your system faster. So this would be for somebody who gets sudden wearing off. So like some people, they have a dose that doesn't work and you take one dose and it just feels like that dose didn't do anything. Or you're out in the store and you should be on your medication schedule, but suddenly you feel like all your Parkinson's symptoms hit you all at once. and you need to treat them quickly, you can take a tablet of Cinemet then, but it takes a while for it to kick into your system. So the idea behind this is that it kicks in a little bit faster, whereas your normal levodopa that you take as a pill would probably take 30 to 45 minutes to work. This would be more like 15 to 30 minutes. So if you have that problem and you have situations where that 15 minutes makes a difference, this can be a very helpful medication. So not really an extended treatment, but it can get you out of that gray area faster. I had one patient who really liked this medication. He found it kind of hard to put the capsules into the inhaler. So what he would do is he actually got several inhalers, and he would put the capsules into them in advance and close them off. And then he had a belt where he had like 3 inhalers in each spot. And he is forever in my memory the Parkinson's cowboy. It looks just like his gun belt or something, that he had these like levodopa inhalers like ready to draw at any moment. So in honor of him, we have the levodopa cowboy. All right. Anywho, there we go. Just a couple more things to talk about here, and then I'll be done. So one of the newer things that's out is cutaneous phospholevodopa, phoscarbidopa. That's a different formulation of levodopa that they use so that it dissolves better in water. And this they give as a continuous infusion under the skin. So it can be very effective at putting you right in the middle of that kind of sweet zone with your levodopa. About 72% of patients who used it did have skin reactions to it, which is not different than other therapies that use this kind of infusion therapy for like diabetes, things like that, but it's something to think about. So you can see the graph there. The green is like the people who are normal carbidopa levodopa. The red is the phospholevodopa infusion. So those people had more. The top is the people with the infusion had more good own time, so that's their treatment's working and they don't have dyskinesia, and they had less time where the treatment wasn't working. And so if this works perfectly, then it's like the straight red line right in the middle. The flip side is some people actually get dyskinesias before they effectively treat their motor symptoms, so can't really fix that. But if you have a good therapeutic window, this is where it would be. There's some other products coming out, so like an actual levodopa, carbidopa infusion that might get approved by the FDA in the near future, and then there's also some dopamine agonists out that are now approved as continuous infusions. All right, so in summary, levodopa is the most effective treatment of Parkinson's motor symptoms. So it is the most effective medication to treat the symptoms of the slowness, the stiffness, and the tremor. The problems that we have with using it to treat those symptoms is that it doesn't last very long, and it has the side effects of dyskinesias, those motor complications. But we do have a lot of options out there for how we can adjust the therapy to address those motor complications and to address that short duration. And so I wanted to give you this so you can think about it, how you're using your medications, if these are issues you're having, and then just think about the time you're taking it, how long does it take to kick in, when is it working its best, and when does it wear off, and all those things we can use to adjust your medication to the best levels for you. All right. So with that, that's all I have. Thank you.
Question. You mentioned Retari and you only mentioned it once. That's carbidopa levodopa and it's slow release, right?
Mm-hmm. Yeah, I was trying not to mention too many things by name. The Rytary and Crixine, you kind of have to because they have the same generic drug name. Oh, sorry. Oh, sorry, you couldn't hear. They have the same generic name. So the Rytary, were you asking about like what it is? So yeah, so it is carbidopa levodopa, and it has a mixture. Well, that one's mostly just like the capsules inside of it. So you take a capsule. Inside that capsule, are more capsules that have carbidopa and levodopa in them, and your body has to break down the first capsule, then break down the next capsules, and it's timed out so that as your body breaks down those capsules, it releases the medicine at a more gradual rate so that it lasts longer.
There's a reason for not really mentioning it.
Oh,
Because
we,
it's
we
that
had,
great.
sorry, I kind of included it under, I had a picture for the new one. Uh-huh. Yeah, I kind of, the right side of the screen there was supposed to say the extended release continuous release capsule, and so Rytary falls under that same name. So I kind of included that one in the Crixont and the same thing. Yeah.
Can you tell me what the difference is between tardive dyskinesia and dyskinesia?
Yeah, so tardive dyskinesia is specifically, the movements can look very similar, but it's specifically a complication of being treated with antidopaminergic medications or antipsychotic medications. So you actually have to be treated with those antipsychotic medications and then develop those symptoms while you're on those to get the tardive dyskinesia diagnosis. That's a completely separate thing from Parkinson's disease, and it's usually mostly in the mouth, but it can be anywhere. You get the same kind of movements in Parkinson's disease as a side effect of levodopa, but they can potentially be anywhere in your body with Parkinson's disease. Mm-hmm. Yes.
Did you mention any side effects from taking entacapone?
Yeah. It's I mean, potentially you can up a lot of the side effects that you have. I didn't list them out there, but I feel like you can run into a lot more complications with dyskinesia. One of the problems that happens when you take extended release medications, whether it's that the continuous release levodopa or you use entacapone to extend it, is if you don't space your doses out right, you start stacking medication, and the amount that's in your bloodstream by the end of the day can be much higher than what's in your bloodstream at the beginning of the day, and you can get really severe dyskinesias as you get later in the day. That's probably one of the main things I run into. Potentially, you can worsen any of the side effects with carbidopa, levodopa, by taking entacapone, though.
I have a question about people who take the medication but don't take it at night during the night. Would an extended drug help, or does it make a difference? I mean,
yeah, it's very common to use Parkinson's medications at night. Rarely ever start anybody that way, but if somebody needs some levodopa at night, whether they're waking up stiff and having a hard time walking to the bathroom, they wake up in the morning really, really stiff because all their medications weren't off from the day before. And sometimes there's some other symptoms in the night that can be treated with levodopa. So some of my patients use it at night, and if I use it at night, I typically actually use that carbidopa levodopa extended release continuous release tablet, that one that I don't use during the day. At night, you don't really notice those fluctuations because you're asleep for the most part. And so I very often do use that at night.
Yes, my doctor started me on ropinirole, and we started out with 4 per day, and then he said there's some complications and we should reduce it to 3 times a day. Is there anything that I should know that I don't know?
Yeah, ropinirole, people for a while, they thought that medications like ropinirole might help slow the progression of Parkinson's disease. The research ultimately didn't bear that out. So there was a little while where they were really popular. And also there was, a big push by the people producing them to say there were less side effects. The reason there were less side effects to a degree was because they were less effective and you were just getting less treatment. So you had less treatment and less side effects. There are unique side effects and certain side effects that are worse with the the dopaminergic agonists, like ropinirole, pramipexole, those kind of medications. They can be a little bit higher risk for hallucinations. They can be higher risk for what we call impulse control disorders. So that's where people can become disinhibited, potentially with doses of those medication. There can be issues with gambling, things like that. And if there's early signs of that, like binge eating or having trouble stopping watching TV, people would often drop doses because of symptoms like that.
I think we have time for one more.
I have a question from the chat. They're asking, how long does the extended release last?
Any of the medications are going to last very differently for every person. In general, that the extended release tablet, or what we call like CR/ER tablet, that tends to add on about 30 minutes to an hour to the dose, but it's inconsistent. The capsules, the Rytary or the Crixant, tend to add about an hour to 2 hours to each dose.
Oh, we have one more. Did one of you guys have a question?
When I take a dose of carbidopa, levodopa, is the length of time that it takes for it to become effective affected by how active I might be?
Yes, it can be. A lot of what is actually affected there is more with like gut motility. So there's more problems if you take the medicine and it sits in your stomach and can't get absorbed. That's an issue. If you're active, you probably have more bowel movement, and then it can actually move along and get absorbed. That might be one explanation for why that happens. If you find it works better if you're active, you might have the opposite. I don't know if I have an explanation for that right off the top of my head, but yes, being active and how well you're controlling constipation can certainly affect how quickly it starts working and how well it works. Okay.
We're almost done, I promise. Maybe. All right. So the next section, we'll have 3 presenters. We'll go quickly-ish. And then, you guys ready for some fun? I guess the no. All right. Naomi, come on up. Naomi is from APDA, Virginia's chapter.
Hello, everyone. Thank you for your patience. I know it's been a long day, so I won't take too much of your time. My name is Naomi McLeod, and I am the program director for the American Parkinson's Association. And so we are a statewide chapter, and so I will be reviewing some of the services that we provide for the entire state of Virginia. Oh, okay. Want to make sure you guys can hear me. All right, so who was familiar with APDA Virginia? Just a show of hands. Okay. Well, hopefully by the time I'm done, you will know how we support the Parkinson's community. So if you may not be familiar with us, we've had several transitions. We started in 1993 in Richmond, Virginia. And so we became from the Richmond chapter to the Hampton Roads chapter, and now we're the state chapter. So all the services that I'll talk about today are for the entire state of Virginia. We are a staff of 2. So I primarily work with the, yeah, it's a lot, so nonprofit world. So I primarily work with the education and program side, and then my colleague Catherine does more of our fundraising efforts. So together we are the staff for APDA Virginia. Oh, and Joel. So we do have a board as well. And so Kathy is also on our board, who's here with us today. And then also Susan used to be our INR coordinator. So she's still very involved with EVA and supports APDA as well. So I'll briefly talk about how we support resources and education for APDA Virginia. So referrals. So when people normally contact APDA Virginia, it's normally because they've been newly diagnosed or they are moving to Virginia. So we are kind of a one-stop shop for anything Parkinson's related. When you call APDA Virginia, you're literally calling my cell phone and my colleague's cell phone. So the great thing about that is that when you call us, you're actually talking to a person, a staff member. We call you back, and we really enjoy that community-based field work, boots on the ground kind of organization. So we have newly diagnosed packets for all of our healthcare professionals, for those who have been newly diagnosed and kind of figuring out what their next their next steps are. So finding a support group, finding an exercise program, finding a second opinion. We've had people call us and they've said, they're saying I have Parkinson's. I really don't know, where should I go to? And we kind of point them in the right direction of what doctors, physical therapists, anybody in the Parkinson's area that we can support. Our website keeps an updated list, or we try to keep an updated list of all of our support groups through the entire state of Virginia based on region, as well as exercise programs across the entire state of Virginia based by regions as well. We also have patient publications. So our table in the back has all a list of education available in English, Spanish, and Mandarin, free. You can download it on our website. Our healthcare providers, you can also download them free or mail them to you for free as well as an ongoing resource for your Parkinson's patients. And so we also have a financial hardship application. And so people don't tend to use that enough. So we offer a one-time $400 grant, one time per year. And so we do it based on an honor system. It can be anything Parkinson's related. So medications, sometimes medications are not covered by insurance. Adapting your home, bathroom renovations, anything Parkinson's related, you just apply on our website. I will call you just to make sure that you're applying for the right reasons, and then you get a check in about 2 weeks. So please, as your Parkinson's progresses or as you're having a need-based, resources or whatnot, we really want to make sure that people know about this great resource that we have available for the entire state of Virginia. So art programs. So we do have an art program that we have. We haven't offered it in this area quite yet. We would love to do so. We're looking forward to starting one in Richmond and starting one in the Northern Virginian area. We focus a lot on, the Parkinson's education side, but we want to also include the socialization aspect as well. So normally we had a Christmas party in Newport News, and so the artists brought music, and we had with care partners, and they were able to come out, and we had cookies and music. And so we really tried to also have the education component, but also the social aspect as well. So we've also partnered with the YMCA of the Peninsulas. And so there's, of course, as you may know, there's several areas throughout Virginia who do not have Parkinson's-based exercise classes. And so we've partnered with the YMCA of the Peninsula, getting ready to partner with the YMCA of Richmond to start. We've been doing a pilot program, an 8-week Parkinson's pilot program in the Peninsulas. And so we're getting ready to create a guidebook so that for other YMCAs who are looking to start Parkinson's-based programs where there's not that available, that we can be able to pass on and continue to provide Parkinson's-based exercises. So as I mentioned earlier, we are a staff of 2, and so partnering with the park and other nonprofits throughout the state really allows us to carry on our mission. So when people call us, we're able to refer them to the park, to POP, to APEX. So we really pride ourselves on partnering with other organizations because we simply can't do it all. And so they're also carrying on the work of supporting the Parkinson's community as well. So we were supposed to have a conference February 21st, but we had a foot of snow. And so we had to reschedule our Parkinson's conference. It does take place in Williamsburg, Virginia. And so if you're open to traveling, we also do record it as well, and we put it on our YouTube channel. So it's an all-day conference from 9 a.m. to 3:30 p.m. We also have breakout sessions. It's about 200 to 250 people who come every year. And so if you're available, we would love to have you. You can register on our website for that as well. And then we'll also have a conference that will take place in September in Roanoke. So we're getting ready to start planning for that next week, actually. Just wanted to highlight that we do offer a newly diagnosed support group for virtual attendees. And so we have several newly diagnosed programs that we offer, but we have not had a virtual newly diagnosed support group. So for anyone who's been diagnosed in the last 5 years, you can register on our website under support groups. It's right at the top of that page. And so we welcome care partners and those with Parkinson's who have been newly diagnosed as well. And then also, it's a little bit of a small image, but we are a chapter, so we are the Virginia chapter. But nationally, APDA also has webinars. We had our virtual conference that took place in February. They have free dance classes, exercise classes. They're now doing an improv class. So if there are always things that APDA is doing, other chapters are also doing other programs that you're more than welcome to attend to as well. So nationally at APDA or our chapter, there's always something going on that you're more than welcome to attend as well. Some upcoming events. So we do have our walk that's taking place. It is in Norfolk. We're doing several walks. And so the money that we raise goes towards doing programs such as our conference, our art program, having a support group of facilitators. We try to have licensed counselors, social workers who are able to support and lead those facilitating those groups. So and like I said, I know it's in Norfolk, but if you're able to support, we would greatly appreciate it because, like I said, we serve the whole state and we're trying to do so many things. And of course, that takes money to be able to do so. And so we want to continue to support the Parkinson's community statewide. And so we would greatly appreciate any support that you can offer for that. And then finally, ways to get involved in APDA Virginia. So we are a one-stop shop for anything Parkinson's related. We always have events going on virtually and in person. So we have different webinars that we offer. We've covered nutrition, intimacy, driving, and then we also record that and put that on our YouTube page as well. Of course, several in-person programs. We have a newsletter that comes out every other week. And so I know Susan sends that out to several people here in this room today. So our newsletter is a great way of staying up to date of what we have going on in the area. I failed to mention as well that we have a weekly support group that meets every Wednesday that's virtual. And so the first hour is exercise led by a physical therapist. And then the second hour is just talking. And it's really more resource based. I know some people are, not open to support groups. And so this is more so an informal. They have a speaker that comes every month. And so that's also on our website as well. And then finally, APDA is piloting several programs. So we have one program called PRESS. And so it's an 8-week program for those who have been diagnosed with Parkinson's. And so it's a support group format, but it's led by someone who actually is a licensed counselor. And so they're piloting a program called Press On for those who have mid-stage Parkinson's, so after 5 years. So I tend to send Sarah, kind of what we have going on in the area. And so she graciously, advertises it for us. So she's a great resource to kind of know what we have going on in the area. And we're also looking for volunteers. So like I said, we're a staff of 2, and so we're trying to do so much. So if anyone is interested in being able to support locally, we really appreciate it. And that's pretty much it. Oh, I had another slide. You're good. There you go. I'm just going to do it this way. All right. So for most of you guys know, PARC is the Parkinson's Activity Resource Center. We focus on exercise support, education, and socialization. We are a 501c3 nonprofit based here in Charlottesville. That's a nice picture of a couple of us who are actually here. So we offer a couple of programs. We offer yoga, we do rock steady boxing, we do monthly support groups, and we just decided to do quarterly topic-based speakers. We had about 33 people back in March for a speech, and then we're going to have a nutritionist coming in July. We have educational events, social activities, and there we go. All right, yoga. So we have 1 hour-long session twice a week. We have both people with Parkinson's as well as care partners participating in that. Actually, a couple of attendees here participate in yoga. We do seated, standing, and ground exercise, and the instructors do modify for all injuries. We actually have one instructor right here, Pamela, who's in the back, and Nancy, I think, is helping set up for the social hour. We also do rock steady boxing, also an hour-long session. It is non-contact boxing. I know Dr. Fergari did briefly touch about rock steady, so I won't go into too much about that. We offer 10 level 1-2 classes and 7 3-4 classes. It's all based on safety, ability,
We want to make sure that you are comfortable in the class that you are in, also successful in the class, and all of our coaches modify for injuries. We work on strength, coordination, cognition, balance, core, flexibility, everything that you're losing because of Parkinson's, we focus on. We also like to have a lot of fun. So we play Genius Square, we have Blaze Pods. Every single day, the class is different. This is a very nice example of why we box, and that's actually from somebody in Wasatch Front, Idaho, who put that together. But it's a great visual on why we do what we do with our Rocksteady boxing classes. We offer support groups. So on the third Tuesday of the month, we offer it in person at the park, and we also offer it from 6 to 7 on Zoom. Like I said, we just had our March, well, we had April, but our March one was a speech and language pathologist talk about speech issues with Parkinson's. That's a picture of 33 people shoved into our gym. Educational events. So I would say probably about like I said, 40% of you guys attended last year. We had 65 in person. The pictures off to your right are from last year's event. Today, we have over 100 in person, and in 2026, who knows, maybe we will reach 200. We also participate in activities around the community. So the picture to the left is from Pancakes for Parkinson's, which is put on at the UVA lawn. Social activities, we got bingo, we do bowling, we have a potluck, we went to a baseball game last year. Some of you guys are here. We also do a lot of work, a lot of hard work, but we have fun. Yes, that's me in the Mandalorian outfit. There are some quotes that are going to come up next, but I have a couple of questions for you guys to start off before I go any further. Who in this room has Parkinson's or Parkinsonisms? Raise your hand. Who's been put your hand down. I didn't say put your hands down, not yet. Keep them up, keep them up. If you have been diagnosed for less than 6 months, put them down. If you've been diagnosed for less than a year, put it down. Less than 5 years, put it down. Less than 10 years, put it down. 15 years? Raise it up if it's up. Okay, we're at 15. 20? 22? Jack, how many years? 14? Okay. 25 years. 27? 28? 29? 30? 31? 31 years over there. Diagnosed in 1994, right? So we here at the park and at any Parkinson's activity place around the country, around the world, newly diagnosed, people diagnosed for 5 years, 10 years, 15 years, 30 years. So there's no limit to what we can do. We also make sure, like I said, we modify for everybody. So if you're in a wheelchair, we got you exercising. If you can do a 40-inch long jump, we got you exercising a little bit harder. And I'm looking at somebody who can do that. I also like to always do this next activity with our new people. So I'm going to have you guys do it with me. Let's go ahead and put our pointer finger in our right hand out. And now I want you guys in the back doing it too. Pointer finger in front of you and put your pinky underneath from your other hand. Without moving your hands, switch which finger goes. Don't hide me. Don't hide it from me. Without moving your hands, the pointer goes on top from one hand to the other. All right, next one. Okay sign on your right hand, peace sign on your left. Without flicking me off, switch them. If you flick me off, you will get a push-up. All right, that's just some of the activities that we do. Like I said, we have fun. So here is a quote from one of our boxers. She started in December and has said that she's felt a huge difference in her body. Also, here's another one. She's here today. She's here in person today. He's working right now. But any place that you exercise with, and I know Dr. Fergari mentioned this, it is a support system and a support group within itself. Okay? You're not sitting around complaining or talking about issues. You are working your butt off trying to fight back that disease as much as you can. So find a place locally. I know probably about like 15 of you guys aren't even from Charlottesville. You guys have local. I know you guys over there down in Lynchburg goes to the YMCA in Lynchburg. There's Lexington. There's rock steadies all over, and also Richmond has rock steadies, and Pops has stuff through Gold's Gym. All right. So for those who don't know, we are located across from Lowe's on 29 North. And a lot of people are like, what do I do? How do I get involved? So either email me or call me. Yes, that's my cell phone number. So don't call me at 10 o'clock at night. Most all exercise places do require for you to do intake forms. We require a medical release form. If you are here in Charlottesville and your doctor is at UVA, send them a message on my chart. They'll get it to me within a couple hours, right, Joy? Yeah. And then schedule an assessment and we fight back against Parkinson's. I always like to suggest you come and observe a class. Talk to your coach wherever it is or the person in charge of the program. Tell them about your Parkinson's. Figure out which class level would be best for you. Watch that class so you can feel comfortable in what you're doing. I also want to invite everybody who's not involved with the park to come out to our open house. It is on May 4th, which is in 2 weeks from 2 to 5 at our location. All right. She didn't know she was speaking today. We got Dr. Virginia Gallagher here from the Caregiving, Aging, Resilience, and Dementia Lab at UVA.
Thank you so much for having me, and thank you for pulling this together. I swear I'm not a narcissist. I would not have put my face on the only slide I have. But thank you, Sarah, for pulling that together. I want to introduce myself. I'm a neuropsychologist at UVA, which means I help learn about how your brain and your body is functioning. And oftentimes myself and my colleagues over there, Dr. Riley, are doing evaluations of people who have suspected diseases like Parkinson's disease and Alzheimer's disease. But I'm here today with a little bit of a different hat on, and that's to talk about our research. So we know that Parkinson's disease impacts the person with the disease immensely in terms of your physical functioning, your thinking skills, and so forth. But one area that we really focus on in our lab is how it affects the family members. And so you've heard today about a lot of amazing support programs, in-person support groups, educational support groups, exercise. And we develop programs like that for family members of people with diseases like Parkinson's disease and Alzheimer's disease. And our hunch is that one size doesn't fit all. A retired spouse may be more interested in a face-to-face support group or a Zoom session with a counselor one-on-one. A working family member who is in their 40s, who has a parent with Parkinson's disease or dementia, may need something different. People who care for somebody who's just been diagnosed might be need more information on logistics, legal planning, financial planning, interventions, whereas somebody more caring for somebody who's more progressed may need something different. So how we are going about this is we are conducting a survey study right now of anybody who provides support for somebody with problems with memory or thinking. And so in the back corner there, my colleague Chris Sheehan has lots of flyers that have this QR code, this website, or we can take down your email address. And we need your help to learn what you need and want and how you want it delivered. Do you want podcasts? Do you want more online support groups? Do you want more education sessions? And the information you give us will help us curate different supports for different people at different times in their journeys. We're so grateful for your engagement in this type of work so we can design the best services possible. I really am going to keep it that brief because I think I'm between us and social hour, but happy to answer any questions anybody has. All right, thank you.
All right, so don't forget that I don't know why I capitalized forget, but there is a survey on your table. Please be honest about it. There are going to be blue buckets placed outside, not outside, but in the hallway, to please drop those off when you're done. A lot of the sponsors did leave. I didn't know that until about 30 minutes ago. So we are going to have our social hour next. We have some food, we have gluten-free options, vegetarian options. We have access over to the patio outside. We have some non-alcoholic 0.0% drinks available. We have sparkling cider. We have the drinks in the back. We do still have snacks available, but all the good food is going to be out in the hallway. Please clean up your trash so we don't have to do it all. I really want to do a big thank you to that back corner. It is UVA who came out. APDA, thank you all so much for helping put this together. I hope you guys made some connections. Renee, Lauren, thank you for, who else did the Zoom today? No, just you two? Okay. Thank you all so much. Please enjoy the social hour and take everything you came with.